Good afternoon, everybody. I hope I'm audible. Uh, can anybody confirm that Dr. Priya Jagge is online?
I can confirm.
Okay.
I can confirm. I'm here.
Good afternoon, everyone, and welcome to this session. Our first speaker is Dr. Priya Jagge. She is a professor and head at Cardiovascular Radiology and Endovascular Interventions Department of All India Institute of Medical Sciences, New Delhi. She is a well-known figure in the cardiac imaging field. She has major awards and honors, national lead for audit cardiovascular imaging subspecialty for ICRI and IRIA. She has been the founder president of a cardiovascular radiology education forum, a forum dedicated to advancing cardiovascular education, training, and research in India. She was the founder president of CVRF, and she has been an executive member of Indian Association of Cardiac Imaging. Her area of interest obviously is cardiovascular imaging, both CT and MR, and she also does the vascular interventions. It's over to you, Priya.
Thank you, Dr. Akshay. Am I audible? Hello?
Yes, ma'am, you are.
Yeah, thank you, Dr. Akshay, for your introduction. And it's great to be, part of this academic feast. I have sent my recording and you may start the same, please. All, I would like to thank the organizers for giving me this opportunity to talk on this topic. I'll be talking about coronary CT angiography, its acquisition and interpretation. We all know coronary. I would like to thank the organizers for giving me this opportunity to talk on this topic. I'll be talking about coronary CT angiography, its acquisition and interpretation. We all know coronary CT angiography is different from CT of rest of the parts of the body because this is an artery which is very prone to motion artifacts, not only because of the cardiac motion, but because of the breathing artifacts, which also could lead to some contamination of the slices. So this study has to be ECG gated. It has to be done on a breath hold. You want to see distal coronary arteries, which are less than 1 mm in size. So you want thinner cuts. You want good contrast specification so that even the distalmost vessel is very well seen. And you also have to be lesion oriented. So your scan has to be, if the patient has had a CABG, your scan has to start higher up. Or you would like to do, if you want to see anything else, like say pleural effusion, etc., you would like to have a lesion-oriented protocol to see those particular things. And unlike other areas, here you may need to reconstruct the images at multiple phases of the ECG to get the best images. So it's important to have certain things in mind before you do the coronary CT angiography. While scheduling the patient, there are some instructions which must be given. Important thing is to prepare your patient well, select your image acquisition parameters well, make sure that you optimize your contrast administration and do adequate post-processing. As far as the equipment is concerned, the minimal equipment required is the 16-slice scanner with ECG gating capability. However, that would require a lot of heart rate control. So you need a 64-slice or more MDCT scanner for larger volume coverage and to get best images with the least amount of contrast agent. As far as KV setting is concerned, for normal or larger adults, we keep the settings from 100 to 120 kVs. And obviously with slim patients or pediatric patients, we keep kV less. Tube current, though the higher MAS will give you less noise, but it also produces larger patient dosage and leads to more damage to your tube. So according to a Lara principle, most of these scanners automatically, they adjust the MAS. For the dual slice CT, it is in the range of 560 to 600 MAS. Ideally is to have the entire acquisition done in the single cycle. That is, you acquire all your images in a single heartbeat, and this is something which is possible only with a high-end multi-slice CT or a dual-slice CT. However, most of the lesser generation multi-slice CT scanners use multi-cycle reconstruction, which improves the temporal resolution if the heart rates are fast. So if on a 64 slice CT, the heart rate is more than 80, it will start utilizing the multi-cycle reconstruction. However, if the patient has had a variability of the heart rate, then that can lead to problems. So these are some basic things which you should keep in mind. So KVP usually set between 100 to 120, MAS between 700 to 90, or even 500 to 600 with dual slice CT, which is usually adjusted for the heart rate and usually is 0.2 to 0.43. Most of the equipment nowadays, the multi-slice CTs have iterative reconstruction, which reduces the image noise without compromising the image quality and reduces the tube current and is available across all the scanners capable of doing coronary CT angiography. So at the time of booking your patient, ask them to be NPO. Important thing as far as coronary CT angiography is concerned is tell them to refrain from using any stimulants on the day of the scan. So no coffee, no tea. Pre-medicate as for other areas. For contrast, if the patient is already on beta blocker, tell him to take that beta blocker in the morning with little amount of water. And if the patient is anxious, he may have a high heart rate on the day of the procedure, give him a mild sedative for that. On the day of the procedure, take the heart rate. If you are using the 64 slice CT, then you may have to control the heart rate and bring it down to less than 65 by giving either a metoprolol, which can be given orally or IV, or you could give diltiazem or ivabradine. If you have a dual slows CT like what we have, you don't need to reduce the heart rate as long as the heart rate is regular. So once you are satisfied as far as the heart rate is concerned, go ahead and put a 18 gauge anticubital, take a 18 gauge needle, Renflon in the anticubital vein or in the right basilic vein. Give the instructions to the patient. Tell him that he will hear the instructions for the breath hold. He has to hold the breath hold, and he will have a lot of contrast injected at a fast rate. So he may have the feeling of flushing. Make sure your ECG leads are in the non-hairy part of the chest and or also away from the region of interest, that is away from the region of the heart. Make sure that you rehearse the breath hold with the patient. Again, check the heart rate, and then you can go ahead. We also use NTG spray. So that's a sublingual spray which is given to make the vessels look bigger. Our Indian population usually have smaller vessels. So NTG, we have found it to be very useful and we use it. But make sure you have a look at the blood pressure of the patient and the echo and rule out a poor LV ejection fraction and a severe AS on echo, and make sure that the PP is not less than 100. As far as scan extent is concerned, for the native coronary arteries, the scan should begin at the carina and should end below 2 centimeters below the caudal extent of the heart. Or you may again replan it after you have done your calcium scoring, and then you can again rechange this scan extent. For a bypass patient, if the patient has had only venous grafts, you can start at the top of the arch. However, if the patient is having a rheumaduality or rheuma, then you need to go above the level of the clavicles and start your scan. ECG gating I talked about. So retrospective ECG gating is usually done if you are also interested in the functional assessment of the patient. We use dose modulation, that is the current is maximum in certain phases of the cycle where you are going to reconstruct your coronary arteries. The time for reconstruction you will have to choose. I'll show you one example. So it can depend on the type of the multi-slice CTs you have. So it is usually 70 to 80% of the RR interval for LAD and circumflex, or it could be 40% for RCA sometimes. With the higher end dual slice CTs, the machine the software automatically selects a best systolic and best diastolic phase, which usually suffices. Like I said, ECG dose modulation, so it uses lower tube current during certain parts of the cycles. So this reduces your dose by 40 to 50%, but it can be used only in patients with stable heart rate, because now you don't have the entire data and you cannot review the coronary anatomy at the end of end systole, and you cannot correct the patient for the error in gating. However, it does allow you ventricular functional analysis, so that has to be kept in mind. So go ahead, and then we do the coronary calcium scoring. So for coronary calcium scoring, we take 3 mm slices, so slightly thicker slices, which again are gated, and we look for the calcium and then Gatson scoring. So again, the software is there, which automatically picks up the score. So if you see dense plaque like this, so even if the score is, say, 100, 150. So if you see a dense plaque like this and you think that you cannot report the underlying vessel beneath this plaque, then abandon the procedure. Otherwise, usually more than 400, you will end up having problems in reporting. And if the score is more than 1,000, I suggest you will end up with a non-diagnostic study and you do not do the contrast injection. Like as is obvious, your sensitivity would reduce if you are doing a procedure with a patient who is having coronary calcium. Regarding contrast, what we want is a contrast on the left side of the heart with almost no contrast on the right side of the heart, so that the right coronary artery is not affected by the streaking of the contrast present in the right side of the heart. So what we do is we do a double barrel injector is used, wherein we give a contrast injection, which is followed by a saline bolus to ensure that there is no contrast in the right side when we acquire the coronary CT angiogram. Depending on your type of scanner, but depending on your scan duration, you need to adjust your contrast volume. So roughly it should last throughout your scan duration. So it's the scan duration into your injection rate plus the monitoring, the pre-monitoring time, all that will give you your contrast volume. So for example, if you have a 16 to 40 detector CT, you need a 20 to 22 second scan. So you need a sustained enhancement for a longer duration, whereas for a 64 detector or a dual source, you want an early enhancement for a very short duration. So depending on that, again, your concentration of iodine, because coronary arteries are very small in the distal areas, you need a high concentration. So ideally, your contrast should be more than 350 milligram iodine, or a 400 milligram iodine contrast may be used. Volume of contrast, if you want it for a shorter duration, like I mentioned before, then you need lesser contrast agents, like we are using just 40 or 50 mils instead of 120 to 150 ml, which will be required if you're using a 16 slice scanner. Rate of contrast, again, you want rapid enhancement in the higher detector system. So we give a contrast rate of 5.5 to 6 cc per minute instead of 4 to 5, which may be required if you are going to do your study for a longer duration of time. Saline bolus is done at the same rate as that of the contrast. So we give 30 to 40 ml of saline bolus. So this is a rough idea. So with 16 slice, you need higher contrast, lower rate, and longer acquisition. With a high-end dual source CT, you give less contrast, more of rate, and you need it only for 7 seconds. Timing of acquisition, so we put a ROI, so we use bolus tracking. ROI is placed in the ascending aorta. For the dual slice CT, rather we put it in the descending aorta to make sure that we do not, because the acquisition is so fast, So we put them in the DTA. So do the bolus tracking, and as soon as it reaches the required 100 to 120 Hounsfield unit, the acquisition will start. So this is the type of images you want, not too much of contrast on the right side, not too much of streak artifacts affecting the coronary arteries. I'm not going to talk about anatomy because Dr. Karthik is going to talk about it. So once you have acquired, some machine will make some reconstructions, but for each coronary artery, you need to go back and have a look. For example, if you're looking at this RCA, if you look at these reconstructions, you can clearly see this 45% and 60% are giving you the best image. So you choose and you do selective coronary reconstruction. So each coronary artery, you may have to do individual reconstruction. For example, 45 is giving you good visualization of RCA, but LAD may be seen in another phase. RCA may be seen better in another phase. So you choose and reconstruct your phase accordingly. So we usually reconstruct, we acquire the slices at 0.4 to 0.8 millimeter axial slices, and you choose the best phase where you want to do it. For cardiac function analysis, we select the reconstruction at 3 millimeter contiguous slices for all the 10 phases. And if the patient has had a stent, or the patient has had some calcification, there's a lot of calcification in the coronary artery, you choose the appropriate filter, and you may end up using a sharp filter to have a better look at the lumen inside the stent. It's important to be aware of certain artifacts which may be there because of high rate. For example, blooming artifacts are a big problem if the patient is having calcification. It may lead to overestimation of the degree of stenosis. So this is a blooming artifact, example of the blooming artifact. You can see the entire lumen appears to be occupied by the calcium. But once you change the window, you can see it's not so. And you do have a lumen which is free of calcium. So choose your window and remove this blooming artifact. Sometimes the artifacts may be because of ectopics or arrhythmia which could be there during the acquisition. You may have to do some ECG editing, move your acquisition away from the ectopic beat to get better image. Again, this is another patient who had a PVC during the scan. And once the PVC acquisition was removed from that PVC, it removed the artifact also and showed the significant proximal LAD stenosis. So you could have MIPS, you could have MPRs, and you could have volume rendered images. But remember, always report on your MIPS. So thin MIPS are the way to go when you are reporting your images. You can have these fancy images, coronary vessel tree, VRT to hand over to your patients. You may want to do virtual endoscopy to look at the bifurcation, but these are few and rarely ever required. So MIP are the way to go. So you do 1 mm or 2 mm MIPS and have a look. So this is an example of a proximal LAD significant stenosis with a soft plaque which is there. So this is a volume rendered image showing proximal LAD disease. This is multi-slice CT, which is showing the similar image, and the same is corroborated on the catheter angiogram, just to show you how similar the pictures are. So the sensitivity and specificity is fairly good in late 90s with very with high-end multi-slice CTs. So what you can do is you have the softwares, ask for the softwares for vessel analysis, and these are they can show you the curved outline of the entire curved MPR. It can straighten out the vessel. You can rotate the vessel 360 degree and have a look. So this is you just single click, you choose the vessel, and it shows you all the axial cuts. It shows you in the opened out, and you can rotate it and pick up and see for the eccentricity of the plaque and also quantify your stenosis. As far as reporting is concerned, like I said, you base your reporting on the MIP images most of the time. So whenever you see a stenosis, whenever you see a positive stenosis, go back and make sure it is there in any other phase also. So sometimes this otherwise could be an artifactual stenosis. CADRATS is the standardized reporting system, which was first published in 2016 by the Society of Cardiovascular Computed Tomography, ACR, NASCI, and has been endorsed by American College of Cardiology also. And it was meant to standardize the reporting of the coronary CT angiography to improve communication and to guide the therapy. So these are the various categories which are described. So essentially what it brings out is you do not have to exactly quantify your stenosis. You don't have to exactly mention that this is, 30%, 40, 35%. You just need to be broadly able to identify your patient as less than 50%. That is a patient who will need no further investigation. A patient which is 50 to 70%, that is intermediate stenosis, a patient which may need a functional assessment, so the stenosis may or may not be significant, or a lesion which is clearly significant, that is more than 70%. As far as left main is concerned, it is more than 50%. Ostial LAD and left main, more than 50% is significant. So these are the patients who will need invasive catheter angiography or a functional assessment and a possible PCI. And then there are certain modifiers by reporting. So if you see non-diagnostic, and there are stents, put S, grafts, G, vulnerable plaque. So if you see all these features, mention V. So let's see one or two examples. So this is stenosis, again in the proximal LAD, which is around 50 to 69% in the proximal LAD because of a non-calcified plaque, CADRAT-C. So if you just mention CADRAT-C, it is not telling you about the type of plaque. So remember, CADRAT-C reporting does not replace your description. You need to mention, when you are mentioning LAD, whether it is type 1, type 2, type 3, when you are mentioning your diagonals, mention whether it is moderate size or a good size vessel, because a small diagonal with a significant disease is of no consequence to a cardiologist. But if you mention a large size diagonal with a significant disease, then it has to be revascularized, either by a stent or by a graft. So description is very important. It cannot replace your CADRAT scoring, but your CADRAT scoring does give an idea to the cardiologist about what way to go. So another example, so you have a significant stenosis in the diagonal. There is a mixed plaque with calcified lesions in the LAD, which were non-diagnostic. Then there was stent, which again was non-diagnostic. RCA did not have any significant disease. So this was CADRATS 4A, non-diagnostic with stent. But as you can see, there are multi-vessel involvement. So your description also has to be there, has to precede this CADRAT classification. In our department, our cardiologists, they prefer to have a descriptive report rather than CADRATs. So they don't want to be told what needs to be done with the patient, which the CADRAT implies. So what is important is the description, and that is what we do. So give a descriptive report, write about the distal vessel, write about the branches, whether they are good size or not. To summarize, optimal coronary CT angiography can be done by using appropriate acquisition parameters and optimal contrast administration. Have individualized post-processing, have a look at each and every part of any segment of the coronary artery. If it is not seen in a particular phase, you may have to reconstruct and have a look at all the phases of that particular segment itself. So sometimes you may have to do that. Be familiar with the interpretation and the pitfalls, and try to get the best possible images with minimal artifact, with maximal dose and contrast enhancement with the minimum possible dose. Thank you.
Such an informative lecture. I am sure the residents and faculty would have learned the nuances of the data acquisition, the tips, the pearls, the do's and the don'ts. If there is any question, Dr. Priya can answer it now. Any questions from the audience? Well, if there are no questions, it's time to thank Dr. Priya.
No,
Dr. Jeet
I have
wanted
one.
to ask something. Yeah.
Yeah,
I want
please,
to.
wait a sec, somebody
yeah.
from the audience. Dr. Jeet. Somebody wanted to ask a question? Please.
Priya, I'm Vikram.
Yes.
Told about ECG editing in PVCs. So PVCs will be single spike there, so it will be easy. So my question is whether it is possible to do ECG editing even in patients with atrial fibrillation where every other beat will be irregular. So your comments on that. And second question for you is how do we, because radiation exposure is a major concern in CT. So how do we take care of or reduce the radiation exposure to the patient during CT?
So as far as ectopics is concerned, we can do editing, but yes, you are right. If the patient is having arrhythmia, then obviously we'll end up with artifacts. In such patients with, if you have a high-end multi-slice CT, you can still go ahead and do the imaging. Only thing is, like I said, there may be certain segments which will not be seen in a particular reconstruction. So we may have to do multiple, the extensive post-processing may have to be done. We can still go ahead and do a CT with a high-end CT. But if you have 64 slice, then it will be a problem. It would be better to give the patient any antiarrhythmic and stabilize the heart rate and get the best possible result before you do the coronary CT angiogram. Secondly, regarding contrast with the current modulation, with the tube modulation, current modulation, we are able to reduce the contrast. With our CT, it's around 3 to 4 millisieverts only. So it's quite less. Rather, with the newer sequences which are being used, prospective gated, etc., even less than 1 millisievert, scans have been reported to give very good results.
Dr. Priya, Dr. Ajay here.
Yeah.
I am having very basic question, one of the very basic question. In cases of very severe stenosis, arterial stenosis, the distal part of artery, distal to stenosis, they fails usually late.
Yeah.
So in coronary angio also, do we take the multiple acquisition, delayed acquisitions, and how do we take decision for that?
No. See, here the contrast, we are giving contrast from the venous side. So the collaterals, if the flow is coming from, say, the right. See, what happens in your catheter angiogram? You are doing, suppose you are doing a left LED injection, it's blocked. So you do the RCA injection, or you wait, do the RCA injection, look for the LED filling in the late frames. Here, all the vessels are filling all together. So rather, in the patients with CTO, it has been found that coronary CT angiography will fill the distal vessel also, because all the collaterals are also simultaneously filling. So you don't need another acquisition as such.
So we don't need that in coronary.
Yeah.
Thank you. Now we will welcome our next speaker, Dr. Karthik Ganga, who is alumni of PGI, MD from PGI only. And currently he is working as assistant professor in Jayadev Institute of Cardiovascular Sciences and Research, Bangalore. And to his credit, he is having about 35 publications and 5 book chapters in his very much young age and very short career. So great Karthik. And areas of interest are cardiovascular MRI and endovascular interventions. Yeah, please.
So, hello everyone. I'm going to be talking about Okay, so this is my topic for today. I'm going to be talking about cardiac and coronary anatomy on CT. So just before we begin, I just want to know how many residents are here. We just put up your finger. Okay, so how many of you all report at least 5 cardiac CTs per week? So I just want to know how much experience you all have with cardiac CT. Okay, coronary CTs. So you report at least 5 coronary CTs a week. Okay, so not much experience with cardiac, but you report coronaries. Okay, So anytime we're going to start with an anatomy lecture, and in the afternoon especially, I'm going to try not to put myself to sleep, and I hope not to put you guys to sleep. So I'm going to take a segmental approach to a cardiac anatomy here. So the next talk actually by Dr. Suman will be segmental approach to congenital heart disease or segmental approach to abnormal hearts. So I'm going to like base my anatomy lecture on segmental approach to a normal heart. So there'll be some amount of overlap between my talk and ma'am's talk, but I'm going to stick to normal anatomy and ma'am is going to stick to a segmental approach to congenital heart disease. So whenever we are beginning to learn something, it's best to have a template, best to have a checklist. And this is the checklist that I use in my institute here. So again, a very interesting template, right? Again, but we will look at it in certain segments. So the first thing that we're going to try and evaluate is look at the situs. Then we'll move on to looking at the veins that bring blood into the heart. Then we'll move on to looking at the chambers of the heart specifically. Then we move on to looking at the arteries, which take the blood away from the heart. And then we'll finish off by looking at the pericardium. And then last but not least, even if you're reporting a coronary CT, don't forget to look at the lung parenchyma and mediastinum. And when I was a resident, I always forgot to look at the lung parenchyma when I was doing a coronary CT. Never forget to look at the lung parenchyma. You might end up finding a lung malignancy, for example. So what I used to do personally is whenever I begin reporting, I'll just look at the things that I forget to look first. So I will begin with looking at the lung parenchyma and then finish off with the rest, because anyway, I know I'm going to look at the coronaries. Okay, so the first thing that we're going to start is looking at the situs. So situs basically means are all the organs in the normal location. So the first thing that you're going to look at is abdominal situs. So normally the liver is present on the right, spleen on the left, and the gastric bubble on the right, on the left. If this is abnormal, if it's a mirror image, then it's situs inversus. If you can't really make out, you're going to describe it as ambiguous. The next thing that you're going to look at is a bronchial situs. So the bronchial situs, you know that the right lung is trilobe, left lung is bilobe, and you can make out that the right bronchus is more vertically oriented, and it has a right upper lobe bronchus, followed by which it's called the bronchus intermedius, and then divides into the middle lobe bronchus and the lower lobe bronchus. On the left side, there is no bronchus intermedius. It just divides into the right upper lobe bronchus and then the left upper lobe bronchus and the lower lobe bronchus. So cardiac situs, again, this is easily seen just on the axial section. So if the apex is pointing towards the left, it's levocardia. If it's pointing towards the right, it's dextrocardia. You can't make out, you will describe it as mesocardia. So we just look at an example here. So here are axial sections. So like I said, the first thing that you're going to look at is situs. So we start off with looking at the coronal sections. See, the liver is on the right, spleen is on the left here, and you can see that the gastric bubble is on the left. So this is normal abdominal situs. So the next thing that you're going to look at is the bronchial situs. So you can see that this bronchial branching pattern is normal. You can see the right upper lobe bronchus taking off, followed by the bronchus intermedius, and that divides further on. So this is the left bronchus. Another term that you'll commonly encounter is an eparterial bronchus and a hyparterial bronchus. So on the right side, okay, so this is the right upper lobe bronchus, and this is the pulmonary artery. So the bronchus is superior to the pulmonary artery, and this is known as an eparterial bronchus. And on the other side, this is the left main bronchus, and this is the left pulmonary artery, and you can see the left pulmonary artery is superior. So and the bronchus is inferior to the pulmonary artery. So this is called as a hypoarterial bronchus, and somebody shortened it to hyparterial bronchus on the left side. Okay, so then we move on, and then if you go back to the axial image, you can see that the apex is pointing towards the left. This is levocardia, this is normal. Okay, so the next thing that we're going to look at is the atrial situs, and there are multiple ways of identifying which is the right atrium and which is the left atrium. But the most important one for you guys to remember right now, the takeaway point would be to identify the atrial appendage. So the atrial appendage on the right side is triangular and broad-based, and left atrial appendage is narrow, thinner, and has a finger-like appendage. So if you just look at the axial images again, you can see that this is the right atrial appendage, and you can see that this has a broad opening towards the right atrium. And this is described as a triangle-like appearance, right? And then on the left side, this is the left atrial appendage. It has a narrower orifice, and some anatomist initially described this as finger-like, and you have to now in your exam say this is like a finger-like appendage. Okay, you can see that if you go superiorly, this also looks like a triangle. Don't get confused, just describe it as a finger-like appendage. So once you identify the appendage, you know that this is the right atrium and this is the left atrium. And that's done with the situs. Okay, the next thing that we're going to look at is the veins draining into the heart. And that you can start again with the axial sections. You can see that this is the IVC. The IVC is draining into the right atrium. And then as you go superiorly, you can see the SVC. The SVC also drains into the right atrium. And the third vein that drains into the right atrium is the coronary sinus. This is the largest coronary vein draining the heart, and this one also drains into the right atrium. So three veins draining into the right atrium. The next thing that we're going to look at are the pulmonary veins. The pulmonary veins obviously drain into the left atrium. And there are usually 3 to 5 pulmonary veins draining into the left atrium. So here you can see this is the right upper. And then as you go lower, this is the right lower. Okay, this is the left lower. And then as you go superiorly, you can see that there is a left superior pulmonary vein. Now there can be variations here. There can be 3 pulmonary veins. There can be up to 5 pulmonary veins. Sometimes there can be more. And this is important for you. I mean, especially when you're reporting a case which is referred to you by an electrophysiologist or a cardiologist who reads, who's treating arrhythmias, he would require this information. Okay, so that's why this is practically important. The number of orifices that the number of pulmonary veins that are opening into the left atrium. Okay, so we are done with the pulmonary veins. We move on to the chambers. So the chambers, the first chamber that we're going to try and analyze are the atria. This is the right atrium. We start off with the right atrium, and this is divided into 3 parts. Okay, it has the venous component. It has the right atrial appendage. We have already spoken about the right atrial appendage, and it has a vestibule. Now we're going to look at the right atrium here. So the area where the superior and inferior vena cava drain into is known as the venous component. Okay, there's no actual differentiation between the 3 components. It is just arbitrarily divided. Okay, so we have seen the right atrial appendage, and then we move on to the vestibule. The vestibule basically is the right atrium proper, where the blood pools before it moves on to the ventricle. And similar to the right atrium, the left atrium has the similar 3 components. It has the venous component, it has the appendage, and it has the vestibule. And here again, this becomes the venous component. We have seen the appendage already. And then we move into the vestibule. This is the vestibule. Here, the vestibule in the left atrium is actually relatively more identifiable. It's quite bigger. It's quite separate from the venous component. You can actually draw a line between the venous component and the vestibular component. Okay, so that is done with 3 parts to the right atrium, 3 parts to the left atrium. Right. So now we move on to the AV junctions. So we start off with the mitral valve apparatus. Okay, so the mitral valves, again, you can divide into 3 components. It has the annulus, it has the leaflets, and it has the subvalvular apparatus. So this is a representative image. This shows you the mitral valve. It has the anterior leaflet and it has the posterior leaflet. So 2 leaflets to the mitral valve. Okay, all other valves in the heart have 3 leaflets. The mitral valve has 2 leaflets. That is the anterior and the posterior. Okay, that is to do with the leaflets. So now we'll just do a 3D MPR here. So what I'm going to do next is a little bit important. Is try to create the cardiac claims. So the first thing that you're going to try and do is get it across the long axis of the left ventricle, and you'll get a 2-chamber view here. And then this also you make it parallel to the long axis of the left ventricle, and you'll get an image here, which is the short axis, the true short axis of the heart. Okay, so here, as I go towards the atrium, this is the annulus of the mitral valve. It's D-shaped. Okay, and as you come a little bit more apical, you can see these 2 leaflets, the anterior leaflet and the posterior leaflet. And then as you come even more apical, right, you will start seeing the papillary muscles. So here are the papillary muscles. There are 2 papillary muscles usually in the left ventricle, the anterolateral papillary muscle and the posterior inferior papillary muscle. Sometimes the nomenclature might vary, but generally 2 papillary muscles. Okay, so 2 main papillary muscles, and it's really important to know that these papillary muscles are all inserted on the lateral wall. There is no papillary muscle on the left side of the atrium which will insert on the septal or the septal side. So this is a very important differentiating feature between the left ventricle and the right ventricle. Right. So we move on to the tricuspid valve. Again, same 3 components. It has the annulus, it has the leaflets, it has the subvalvular apparatus. But here it's going to be relatively more difficult to see the papillary muscles on the right side. They're much more thinner, and it's very difficult to differentiate one papillary muscle from the other. And again, you can have 3 to even 5 papillary muscles on the right side. Usually there are 3. Right? The annulus, again, it's very similar. Here there are 3 leaflets. Okay, it has the anterosuperior leaflet, the septal leaflet, and the inferior leaflet. Okay, so here we come back here, And now that we have the true short axis here, we're going to try and create a true 4-chamber view by just turning it this way so that this line intersects the anterolateral papillary muscle and the inferior RV hinge point. So this becomes a true 4-chamber view. Okay. And here is the mitral valve and mitral valve. Here is a tricuspid valve. And you can't see it very clearly, but this is the insertion of the septal leaflet of the tricuspid valve. Okay. And this is the insertion of the mitral valve. You can see that the insertion of the tricuspid leaflet is more apically placed. Okay. This is a distinguishing feature. Again, the tricuspid valve is described as epicophilic and septophilic. So it is closer towards the apex, and you have one leaflet which is directly inserting on the interventricular septum. Okay. And also, like I said, the leaflet, I mean, the subvalvular apparatus here, the papillary muscles are not very clear. You won't be able to make out, but you can make out one papillary muscle here. But the more important point is when you look at the difference between the septal side of the right ventricle and the septal side of the left ventricle, this will be relatively smooth. The left side will be relatively smooth compared to the right side. That's because you will have a lot of trabeculations arising from the septal wall of the right ventricle, and one of the papillary muscles also inserts here. So that is the difference. Okay. So the tricuspid valve again has three components. So we move on to the right and the left ventricle. Again, there are multiple distinguishing features, how to identify which is the right ventricle and which is the left ventricle. Okay, one of the main features and the most commonly quoted feature would be the presence of a moderator band on the right side. So this is the moderator band that you can see here. This structure here, which arises from the septum and then goes on and inserts into the free wall of the right ventricle. So the presence of this moderator band indicates that this is the right ventricle. There are other features. Okay, so the presence of a fibrous left ventricular outflow tract, I'm coming to that, and the trabeculations. Like I told you, the septum on the right ventricle is coarser, and the septum is not smooth on the right ventricle side. On the left ventricular side, it will be very smooth. Okay, and the presence of a moderator band in the right ventricle. Okay, so now again, the right ventricle can be divided into 3 parts. So I'm going to try and show you the right ventricle cavity proper. So this is the right ventricle. So it is divided into the inlet, the apex, and the outlet. So this is the inlet closer to the tricuspid valve. This is the apical part of the trabecular part, and this is the outlet where it gives rise to the pulmonary artery. Okay, here in the right ventricle, it's relatively easy to distinguish the three parts. In the left ventricle, it's not very difficult, not very easy to distinguish the 3 parts. What's important to note here is this is the outlet. So look at the muscle here and look at the muscle here. Okay, so the outlet in the right ventricle is completely muscular, okay, as opposed to the left ventricle. So you have muscle surrounding the entire outlet of the right ventricular outflow. Okay, this is known as a muscular outflow tract. The left ventricle is partly muscular and partly fibrous. I'll come to that. Okay, so now we move on to the left ventricle. So I'm going to try and show you the left ventricular view here, left ventricular outflow tract. So this is a 3-chamber view here. Okay, so you can see that this is the left atrium, this is the left ventricle, and this is giving rise to the aorta. So this part is known as the inlet, this is the ventricle proper, and this is the outlet. You can see that there is no general differentiation. It's very difficult. There's no demarcation between the inlet and the outlet. And very important to notice that there is aortomitral continuity. Okay, so this is the anterior leaflet of the mitral valve, and this is the non-coronary cusp of the aorta, and these both are connected by a fibrous tissue, and this is known as the aortomitral continuity. And the tricuspid valve, the aortic valve, and the mitral valve are all connected by fibrous part of the heart. Okay, so this you can make out that one wall of the outlet is muscular, one wall is not muscular, it is fibrous. So this basically tells you that this is the left ventricular outflow tract. Okay, if you see muscle all around, then it will be the right ventricular outflow tract. If you don't see muscle all around, if you see one is muscular and one is fibrous, that makes this the LVOT. Okay, so we've talked about this. Now, how do we now divide the left ventricular cavity proper? Okay, the left ventricle is a big structure. So how do you divide it into basal, mid, and apical? So you start here, right at the mitral valve, and you go all the way up till where you can see the tips of the papillary muscle. So from the annulus till the tips of the papillary muscle, that's the basal segments. Okay, so from the tips of the papillary muscle till where the papillary muscle inserts, that is the mid part of the left ventricular cavity, and distal to that, it becomes the apical part. Okay, so This is the basal segment, this is the mid segment, this is the apical segment. Now, how do you divide it into 17 segments? So we divide the left ventricular myocardium into 17 segments. So you first just basically put an X, draw an X on it. Once you draw the short axis view, once you get the short axis view, just put an X on it. Okay, and then draw another line which connects the mid part of the septum to the lateral wall, and that gives you 6 segments in the basal segment. Okay, and then similarly in the mid segment, and so similarly in the apical segment, just draw the X. Don't draw the line in between. So this gives you 16 segments. Okay, and here's how you identify which segment is which. This is the nomenclature. So this is the anterior segment. This is the septal segment, very easy to identify. The one opposite that is the lateral segment, very easy to identify, and the lowermost is the inferior segment. Okay, so segment 2 becomes anteroseptal, and segment 3 becomes infroseptal. Okay, so this is the way you divide the left ventricular myocardium into 17 segments. So 16 you see here, and the 17th you see on the long axis views. The 17th is the true apex of the left ventricular myocardium. So let's go on to the interventricular septum. So the interventricular septum again divided into 2 parts: the membranous interventricular septum and the muscular interventricular septum. So when you see the 4-chamber view, you can see that right at the junction, at the atrioventricular junction, it's a very thin interventricular septum, and this is the membranous part. The rest of it is a thick fibrous muscle. Okay, so that is the muscular septum, and the muscular septum is again divided into 3. So there is a theme here. Many things in the heart are divided into 3, or can be classified into 3 subdivisions. Okay, so just this is a good way to keep track of how you classify things in the heart. It has the inlet, it has the trabecular portion, it has the outlet. So here's the view from the right ventricular side. You can see the portion closest to the atrioventricular junction is the membranous septum. The closest towards the tricuspid valve will be the inlet septum. The one towards the apex is the trabecular or the apical septum, and towards the outlet becomes the outlet septum. And if you have a VSD in the membranous septum, it's called a perimembranous VSD. If it's in the inlet septum, it's called the inlet VSD. If it's in the outlet, it's called the outlet VSD. And if it's in the trabecular septum, you can call it a trabecular VSD, but it's more generally called as a muscular VSD or a mid-muscular VSD. Okay, so that's to do with the interventricular septum. Now we move on to the great arteries. So the left ventricle gives rise to the aorta, the right ventricle gives rise to the pulmonary artery. And how do you know which is the aorta and which is the pulmonary artery? Sometimes in a case of complex congenital heart disease, you will not be able to make out. So you will be able to make out that it's the aorta based on the branching pattern. The vessel that gives rise to the innominate artery, the carotids, that becomes the aorta. And the one that branches into the right pulmonary artery and left pulmonary obviously is the main pulmonary artery. Okay, so we'll just reset this. And now we'll look at the leaflets of the aortic valve. So like I said, all the valves generally in the heart, except the mitral valve, has 3 leaflets. Okay, so if you look at this, it has 3 leaflets. This is the aortic valve. Okay, and the leaflet and the cusp that is opposite the interatrial septum, that is the non-coronary cusp. The other 2, the one towards the right is the right, and the one towards the left is the left coronary cusp. And the left coronary cusp gives rise to the left coronary artery, and the right gives rise to the right. Okay, similarly, the pulmonary valve has three sinuses, but they don't give rise to coronary arteries generally, normally. Okay, so we move on to the coronary arteries now. So the coronary arteries are, like I said, the right coronary artery arises from the right coronary cusp, left rises from the right coronary sinus. I'm sorry. So we'll just look at a little bit of theory right now. So the right coronary artery is divided into 3 again. So the first part of the right coronary artery is from the ostium till 1/2 of the distance to the acute margin of the heart. Okay, and the second, the mid RCA, it starts from the end of the above segment and runs up to the acute margin of the heart. And the distal is from the acute margin of the heart till when it bifurcates. And it continues as a posterior descending artery. The posterior descending artery continues in the posterior interventricular group. And then we look at the left main coronary artery. So the left main coronary artery divides generally into 2. It can divide into 3, generally into the left anterior descending artery and the circumflex artery. Sometimes the ramus can arise from where it bifurcates. Okay, right from where it bifurcates here. So the LAD again divided into 3. So the proximal, mid, and distal LAD. Okay, so the proximal LAD is from the origin to where the first septal or the first diagonal branch is seen. Sometimes you can't see the septal perforator. So the first part extends up to the diagonal. So the mid part extends from this segment to generally the second diagonal or 1/2 of the distance till the apex of the heart. And the rest of the LED is known as distal LED. Okay, the LED gives rise to septal perforator and it gives rise to diagonals. Okay, and then you look at the circumflex artery. The circumflex can be divided into proximal, mid, and distal. Proximal and distal. Sorry, here again it's divided into 2 and not 3. Okay, so the proximal is from the origin to the origin of the obtuse marginals. The obtuse marginals arise from the circumflex artery. Okay, and distal is from the origin of the first obtuse margin till where it terminates. Okay, and dominance, obviously, you guys know that it depends on where the PDA arises from. If the PDA arises from the right, it's the right dominance, more common. And if it arises from the left, it's left dominant. And if both of them give rise to branches that supply the posterior part of the heart, then it is called codominant. Okay, so now why is it important? Again, I come back to this diagram and I told you how to divide it. Just draw an X and then draw this line in between. And now the LED supplies the anterior and the anteroseptal segments. The RCA supplies the infroseptal and the inferior segments, and the LED supplies the lateral segments. That's why it's important to know this. Okay, so here's another diagrammatic representation of the 17 segments of the heart. And when I say 17 segments of the coronary tree, so there are 17 segments of the coronary arteries, and there are 17 segments of the left ventricular myocardium. But these are not mutually exclusive. Okay, segment 1 of the left ventricular myocardium is not supplied by the coronary artery segment 1. They're just arbitrary. They're two different things. Do not confuse them. Okay, there are 17 segments of the coronary artery and the 17 segments of the left ventricular myocardium. They both are different. Okay, so don't get confused with that. So I'll just briefly look at some of the, I'll show you some pictures. If I have time, I'll move on to the, I don't have time. So I'll just show you images here. So this is the right coronary artery, and that divides into the posterior descending artery and the PDA and the PLV. Okay, and this is the left main, which divides into left anterior descending and the left circumflex. The LED gives rise to the diagonals, and the LCX gives rise to the obtuse marginals. Okay, I'll just move on. I'll just try and finish before my time runs out. So another thing that is important to cover is the coronary veins. And this is an entire lecture in itself, but it's not really very important when you're reporting, because personally, I've never come across an instance where they've come back to me and asked me to look at the coronary anatomy. But what is really important to know is that there is the coronary sinus, we saw that before, and the tributaries of the coronary sinus. Now, this is important practically because if you get a case from an electrophysiologist, he puts one of the leads of the pacemaker in one of these vessels. Okay, he either leaves the lead in the coronary sinus or one of the tributaries of the coronary sinus. So coronary sinus, one of the tributaries which are there posteriorly. So that is why it's important to know. Otherwise, coronary veins generally, no cardiologist has actually come back to me and said, show me the coronary vein anatomy, because they're very comfortable doing this just in the cath lab. Okay, so we'll move on to the pericardium. The CT is particularly sensitive for identifying pericardial calcium. So if it is normal, it'll be just an imperceptible thin structure. So you won't exactly be able to make it out. Okay, but if you can make out if it's thickened or if it has calcium or if it's enhancing. All these suggest that if there is pericarditis or chronic calcific pericarditis. Okay, what is important to know is that there are some parts of the pericardium. Okay, so the main parts of the pericardium are the transverse sinus and the oblique sinus, and each of them have some recesses. Okay, these recesses are cul-de-sacs where fluid can accumulate, and when fluid gets accumulated there, it might simulate pathology. So we just look at the superior and inferior aortic recess here. So this is a superior aortic recess, and if you just look at one section, you can mistake this for a lymph node. So that's where you need to scroll down, and you can see continuity with the pericardium, and you should not mistake this for a lymph node. Okay, and similarly, this is the anterior part of the superior aortic recess, which you can look at this. This is also the anterior part. It very closely mimics a lymph node. Okay, you should not mistake this with a lymph node. So the next part is the right and left pulmonary recesses, and as it suggests, it's associated with the right and left pulmonary artery. And again, if fluid accumulates only there, it can mimic pathology. When we move on to the postcable recess, again, postcable basically means that it is around the superior vena cava, and presence of fluid here suggests that it could simulate pathology again. And the last is the oblique sinus, and the oblique sinus is in front of the esophagus. Okay, so if fluid accumulates there, you will see some a lesion simulating a lymph node there. Again, don't mistake it for a lymph node. Just scroll up and down, and you'll be able to make out that this is the recess. Okay, and pulmonary venous recesses are also there, and these are around the pulmonary veins, and fluid can accumulate there and mimic pathology or thickening of the pulmonary vein wall. So we come to my initial side where this is, the approach to normal cardiac anatomy. So just divide it into different segments. Assess the situs first. Look at the veins that drain into the heart. That includes both the vena cava as well as the pulmonary veins. Look at the chambers, each chamber specifically. Then look at the arteries that drain the heart. That is the aorta and the pulmonary arteries. Finish by looking at the pericardium. And do not forget to look at the lungs. Okay, that's very important. Okay, thank you. That's the end of my talk.
Thanks, Dr. Karthik, for detailed and very basic knowledge of the coronary anatomy, and very smart presentation between the MAC and your Osirix. This thing that was very impressive. So, any questions? Any short questions we can take?
Yes.
Divide LED on the basis of the length of LED, whether it is sitting up to the apex or it goes below it.
Yeah. So Dr. Priya actually talked about type 1, type 2, and type 3 LED. Right? So the LED reaches right up to, it does not reach up to the apex, it's called type 1. If it reaches up to the apex, it's called type 2. If it goes beyond the apex, it's called type 3.
Thank you, sir.
So if there are no more questions, it's a pleasure to invite the next speaker, Dr. Suman Singhal, who is currently Director of Cardiac Imaging for this Escorts Hospital Jaipur. She has been former Vice President of IRA Delhi. She shall be talking about the segmental and simplified approach to congenital heart on CT, cardiac CT. So over to you, Dr. Suman Singhal.
A very good afternoon to everyone. First of all, I would like to thank the organizing team, especially Dr. Manful Singhal and Dr. Ravindra Kaur, for giving me the opportunity to be part of this annual conference of Chandigarh chapter of IR. I'll be speaking on sequential and simplified approach to congenital heart disease on CT. Segmental sequential approach is widely used in congenital heart disease in both CT as well as MRI. The main strength of using this approach is that it is easy to use, it is very systematic, and we are able to communicate in the same language with the cardiologists and cardiac surgeons who are going to manage the child later. Segmental sequential approach is based on 3 stages: anatomical description of each segment, that is cardiac anatomy, the relationship between each segment, and the related intra and intersegmental anomalies. So in this 20 to 25 minutes, I would like to make it as simplified as possible. First of all, the anatomical description of each segment. So Van Praag in 1960s came up with this segmental approach in order to define the cardiac anatomy in congenital heart disease. Through this approach, the heart is separated into 3 different segments: viscoatrial situs, the ventricles, and the position of great vessels. So Van Praag came up with this annotation system with a series of 3 letters separated by commas. The first letter signifies the viscoatrial situs, the second letter signifies ventricular loop orientation, and the third letter signifies the position and relationship of the great vessels. So this is the atria, these are the ventricles, and these are the great vessels. So in this way, Van Praag described the cardiac anatomy. Now later on in 1970s, Anderson and colleagues came up that we should tell about the anomalies of the junctions, that how the chambers are connected and related. So the atrioventricular junction anomalies and as well the ventriculo-arterial junction anomalies. So this is how we do the anatomy and the sequential approach now, in which the step 1 is to find the viscoatrial situs, step 2 is the ventricular loop orientation, step 3 is position and relationship of the great vessels, and then we see the connections, the atrioventricular connections and the ventriculo-arterial connections. And we'll put it all together to describe the congenital heart disease. Now taking them one by one, the visceroatrial situs. As the name signifies, we have to see how is the position of the atria and viscera related to the midline. So there are three types of situs: situs solitus, where we use the word S; situs inversus, that is mirroring of the anatomy, that we use the I; and ambiguous, where we use the word A, which is heterotexy. Ambiguous is defined as an anomaly of situs other than solitus or inversus. So how do we first of all decide between a morphological atria, right atrium, or a left atrium? In a morphological right atrium, there is trapezoidal appendage, which is broad in connection to the chamber. There are pectinate muscles which extend from the appendage towards the atrioventricular canal. There are superior and inferior limbic bands on the septal surface. There is crista terminalis, and usually the morphological right atrium receives the blood from coronary sinus as well as supradiaphragmatic IVC. Morphological left atrium is a tubular appendage with a narrow connection to the chamber, and there are pectinate muscles within the tubular appendage. The simplified way to describe or to identify a morphological right atrium or the left atrium is to identify the atrial appendages, which are their extensions. So whenever we see a broad and a triangular appendage, we call it a right atrium. And when it is a tubular, narrow appendage, a finger-like projection, we call it a morphological left atrium. In a normal situs solitus, the things are that what we see normally in a patient, that on the right side of the patient, there is atrium of the right morphology. On the left side, there is atria of the left morphology. In the abdomen, the liver will be on the right side, the spleen will be on the left side, the lung with 3 lobes will be on the right side and with a eparterial bronchial anatomy, and on the left side will be bilobed lung with a hip arterial bronchial anatomy, where the bronchus will be low down the artery. And if the anatomical configuration is reversed, it is a situs inversus. So this is how a situs solitus will look like, which is a normally we see, and situs inversus is totally mirroring of this, where the heart is on the right side, the liver is on the left side, spleen is on the right side. So this is how a situs inversus will look like. This is situs solitus, again just a pictorial diagram to show that how a bilobed lung and a trilobed lung will look, and how the liver will be on the right side, spleen on the left. Inversus is totally opposite of that, and situs ambiguous or heterotexy is a mixture of two, that is right and left isomerism. Now, practically, when we are not able to, in a complex heart disease, we are not able to justify or identify which is the right or left atrial appendage, then we use the other characteristics. We look for the coronary sinus or the supradiaphragmatic IVC, and that is practically very helpful. Any coronary sinus draining into the atria is usually the right atrium, and otherwise we use the bronchial and pulmonary lobar anatomy, that how is the upper lobe bronchus, whether it is eparterial, that is towards the right side, and if it is a hip arterial bronchus, that is a left anatomy which is there. So this is how the eparterial bronchial anatomy will be there, where the right bronchus is posterior to the artery. And this is a hip arterial bronchial anatomy, where the upper lobe bronchus is passing inferior to the left pulmonary artery. So this bronchial anatomy or the coronary sinus entering the atria helps us to identify further when we are not able to identify the right and left morphological atria. This is a situs ambiguous. It is two major forms are there, right isomerism or left isomerism. Right isomerism is asplenia, where there is spleen is not there. Bilateral, we have 3 lobe lungs, eparterial bronchi, midline liver, bilateral right atrial appendage, and there can be ipsilateral position of the abdominal aorta and IVC. Left isomerism is basically polysplenia and left-sided anatomy basically. So bilateral two-lobe lungs, hip arterial bronchi, midline liver, bilateral left atria appendage, or sometimes accompanied with interrupted IVC and azygous connections. So this is just a case of left isomerism. As we are seeing that it is ambiguous, the dextrocardia is there, there are multiple spleen, circumaortic left renal vein is there, midline liver. So we know this is situs ambiguous. And why we are calling it left isomerism? Because we are seeing the bilateral, bilobed bronchial anatomy, bilobed lungs with a hip arterial bronchial anatomy. And this is the patient also has double SVC. So this is a left isomerism. Now coming to the step 2, that is the ventricular morphology, bulboventricular loop. So only 2 types of ventricular loops exist, right that we denote by D or left that we denote by L, that is levo. So D is when the right ventricle on the right side of the left ventricle is present. So as the ventricle is basically a tubular structure, and during embryology, whether it turns towards the right or towards the left side. So when it turns towards the right side or the D loop, so the right ventricle will be on the right side of the left ventricle. We call it a D loop of the bulboventricular or the ventricular morphology. When the loop is towards the left side, then the right ventricle is on the left side of the LV. So we call it a L bulboventricular loop. So how do we identify morphological right ventricle from the morphological left ventricle? See, this morphological and anatomical are different. So this is very, very important in congenital heart disease to identify a morphological atria or the morphological ventricle, and then looking at their anatomy on which part of the thorax they are located. And that's helped us a lot to further define the anatomy in the congenital heart disease. Morphological right ventricle has coarse trabeculae, papillary muscles are attached to the free wall and the interventricular septum. There is a moderator band extending from the anterior papillary muscle to the septum, which identifies the morphological right ventricle. Now, morphological left ventricle has fine trabeculae, papillary muscles are attached to the free wall, and it has a smooth septal surface. So here we see it on the CT, this axial section, that right ventricle, lot of coarse trabeculae, there is a moderator band, the papillary muscles are attached to free wall as well as the septum, while in the left ventricle, fine trabeculae, the papillary muscles are attached to the free wall and the septal surface is completely smooth. So this is a morphological right ventricle and this is a morphological left ventricle. So is the morphological RV is rightward to the morphological LV? If the answer to this question is yes, we call it a D loop. If the right ventricle is to the left of the morphological left ventricle, we call it a L loop. In complex cases, we use hand or the loop rule. According to the hand rule, you identify the morphological right ventricle, keep your palm against the interventricular septum, the thumb in the RVOT, and fingers in the outflow tract. So in the normal ventricular configuration, the right hand will always fit in the right ventricle, and the left hand will fit in the left ventricle. But if there is a D loop, that is normally the right hand will fit in the right ventricle. But if it's a L loop, the left hand will fit into the morphological right ventricle. The loop rule says that right location of the aortic valve with regard to the pulmonary valve. So in the right bulboventricular loop or the D loop, there is aorta will be on the right side of the pulmonary artery. But with the L loop or the reverse, the aorta will be on the left side of the pulmonary artery. So that is a L loop. And mitral valve will be in the left ventricle and tricuspid valve with the right ventricle. So at this position, I would also like to say that we have to define the cardiac base axis, how is the apex base axis, and the cardiac position. When do we call dextro position and when do we call dextrocardia? So cardiac position is basically the position of the heart as respect to the thorax. So dextro position is when the heart is on the right side of the thorax, we call it dextro position. When the heart is in midline, we call it meso position. And when the heart is on the left side in the thorax, we call it levo position. When we define the base apex axis, that the base apex axis is towards the right side, it is dextrocardia. If it's towards the left side, it is levocardia, that is a normal position. And if the base apex axis is in the midline, we call it mesocardia. So here this is dextrocardia because the base apex axis of the heart is towards the right side. In this patient of pulmonary hypoplasia, there is shifting of the heart towards the right side of the thorax, but the base apex axis is still on the left side. So this is dextro position and not dextrocardia. So we need to see this cardiac position and the base apex axis very well to see, call it dextrocardia or levocardia or dextro position or meso position. Now coming to the step 3, that is the great vessels or conotruncus. According to the Van Praagh theory, the embryonic aortic valve is located anterior to the pulmonary valve in the embryonic level. But when the normal ventricular loop is created, the valve becomes side to side to the pulmonary valve. So the aorta will be on the side of the pulmonary artery and the valve will be on the side to side. This is normal. And yes, so this is what is normal in a situs solitus when the aortic valve will be on the right side of the pulmonary valve, and in situs inversus where the aortic valve will be on the left side of the pulmonary valve. Now, during development, muscle under the aortic valve resorbs, whereas the subpulmonary conus grows. So presence of conus beneath the pulmonary or aortic valve usually indicates that this vessel is arising from the right ventricle. So this is how a subpulmonary conus looks like. Normally, like there is no conus behind the aortic valve, so there is just a fibrous continuity between the mitral valve. Here, since there is a conus, there is continuity between the tricuspid and the pulmonary valve. So whenever we see this muscular conus beneath the pulmonary or the aortic valve, this tells us that this vessel is arising from right ventricle. Now there are 4 possible types of conal anatomy are there. Subpulmonary conus, which is normal, as we are seeing here. There can be subaortic conus, as we are seeing here. It can be bilateral conus, as we are seeing here, and there can be bilateral absent conus as well. So these are different conus anatomy which one can come across during seeing a congenital analysis. Now, transmission of great arteries is, as the name signifies, that it is a reverse of the great arteries. When the aorta is arising from the artery and the pulmonary arteries arising from the LV. Classically, in transposition, a subaortic conus is present because it is arising from the artery, and there is no subpulmonary conus because it is arising from the LV. If the ventricular region of a great vessel cannot be identified, or if the great vessels are arising from a single ventricle, the malposition of great arteries is more appropriate. So malposition of great arteries is when the arteries are originating from the same ventricle, or there is overriding, like it can be a DORV or a DOLV, that is double outlet ventricle or a double outlet left ventricle. And in this we call it DMGV, that is dextro position or malposition of great vessels when the aorta is on the right of the pulmonary artery. And if its aorta is on the left of the pulmonary artery, we call it L or levo position of the malposition of the great vessels. In a double outlet right ventricle, a dual bonus is usually present. So this is a very important diagram, just one should remember, because it really helps us to identify at this great artery how is the cytological inversus or a TG. So this is the normal cytosolitis where we will see the aorta posterior and towards the right of the pulmonary artery. With reverse, we vessels. In the transposition of great vessels, if the aorta is anterior and towards the right, it is DTV, and if it's towards the left and anteriorly, it is LTV, TGV, or the levo transposition of the great vessels. This is how it will look on a CT. This is normal. This is situs inversus, where aorta is on the left, and if the aorta is anterior and towards the right, this is the DTGV, and if it's on the left side of the pulmonary artery and anteriorly, it is LTG. Now, DTG is a completely unconnected transposition of great arteries or great vessels. So this is the three-letter annotation which Van Praag had come up. So cytosolitis, the D bulboventricular loop, dextro-bulboventricular loop, and the DTGA. That is, the aorta is towards the right of the pulmonary artery. So right atrium gives to the right ventricle, but aorta is rising from RV. Left atrium, left ventricle, pulmonary artery are rising from the LV, as we can see it here also. This is an unconnected transposition of great vessels. Now, talking about the LTGA, basically where there is cytosolitis, levo position of the bulboventricular loop, and levo position of the transposition of great arteries. So here there is atrioventricular discordance as well as a ventricular arterial discordance. So right atrium attaches to right ventricle, which further attaches to pulmonary artery. The left atrium attaches to RV, and which further communicating with aorta. So this atrioventricular discordance as well as a ventricular arterial discordance causes a physiological correction of transposition of great arteries. So after completing the anatomy, let's talk about the relationship between each segment. So in relationship between each segment, we talk about atrioventricular junctions as well as a ventricular arterial junctions, and try to put it all together to solve the puzzle of congenital heart disease. The atrioventricular connections are classified by the number of ventricles, biventricular or ventricular. So biventricular atrioventricular connections can be normal, that is concordance. It can be discordance. AV discordance can be there. It can be tricuspid mitral aplasia, as shown here. In univentricular atrioventricular connections, it can be common AV valve between the two-sided chambers. There can be overriding of aorta, like shown here, or there can be a double inlet ventricle. So this is overriding of aorta, we commonly see in patients of TOF. In ventricular arterial connections, it can be also four types: concordance, that is normal. It can be discordance, that is transposition of great arteries, which we talked about. It can be double outlet right ventricle or DORV, or double outlet left ventricle, that is DOLV. It can be single outlet aortic ventricle with aortic or pulmonary atresia and a common arterial trunk. So this is how a double outlet right ventricle looks like, where usually there is a VSD so that they can communicate with RV, as both the great arteries are rising from RV. In DOLV, that is double outlet left ventricle, both the great arteries are arising from left ventricle. Now, after looking at all these, we have to look at the related intra and intersegment abnormalities. So there is this huge the table which is there and there is a lot of variations which is possible. So one has to look that what kind of associated anomaly which is there in a congenital heart disease and try to put it all together to solve the problem. This is how just as associated anomalies I'm showing. This is a double SVC which is there with the right-sided aortic arch. This is a double aortic arch which we found in one patient. Here how the double aortic arch is seen here. Not just a small case, so that we have a feel of how do we apply this approach to different cases of congenital heart disease. So here we are seeing first of all the visceroatrial situs. So visceroatrial situs, we are seeing that the cardiac base apex axis heads towards the right side. So this is dextrocardia. We are seeing that there is the stomach is towards the left side. So this is basically situs ambiguous. Then we are seeing that there is a right-sided bronchial anatomy bilaterally. There are right-sided broad triangular shaped atria. So basically this is right-sided anatomy which is there, and this is right isomerism. When we are seeing that there is when we talk about the bulboventricular loop, we are seeing that the RV is towards the right of the LV. So this is D loop. Then we come to the great vessels and we see that the aorta is towards the right side of the pulmonary artery. So again the D position is there and the aorta is arising from RV and the pulmonary artery is arising from LV. So this is basically a case of situs ambiguous, D position of the bulboventricular loop, the D TGA with right isomerism, atrioventricular concordance, and arterioventricular discordance, which is there. This case I love to show. This was a 2-day-old child who had come to us to look for the coronary anatomy. And this was kind of challenge case to us that if we are able to do in such a small child a CT where we cannot control the heart rate or the respiratory rate, and with few ml of contrast which we can give to the child looking at the weight of the baby. So this we had done and we could easily see the coronary arteries, and in this case of TGA we were able to show the origins of the coronary artery very well. Between the pulmonary arteries we can see that the aorta is arising from RV and MPA is arising from LV. So just to show that on CT, a well-performed CT, not much is possible. Nowadays, for the CT machine which we have, it has a helical shuttle, which is there, a volume helical shuttle, where with the same contrast, we can get in a loop that how the contrast is flowing. As we can see, with the same contrast, we can see how the contrast is flowing in the arteries, and we can see the aortopulmonary window very well. Because in these small children, we cannot control the heart rate or the respiratory rate, and we have to use a very little of contrast with all the radiation protection measures. Nowadays, 3D printing is also there to demonstrate the complex cardiac anatomy. So in the end, I would like to summarize that in sequential approach and a simplified approach, one should look at the cardiac anatomy, the visceroatrial situs, the bulboventricular loop, the great vessels, then look at the connections, and then look at the associated anomalies, and we will be able to see what kind of congenital heart disease is present. Thank you so much.
Thank you, Suman, for elaborating on a very systematic and step-by-step approach to the assessment of congenital heart disease. It is in fact a very complex topic, and you have made it very simple. But still, I think residents will have many questions to you. So if there are any questions from the audience, please forward to Dr. Suman. So if there are no questions, we can end this session, and we thank technical chapter of IRA for making us part of this conference. It's a pleasure running this conference and chairing the inaugural session. Thank you very much.
Thank you.
Thank you, sir. Thank you so much.
I hope that was an educational and informative session for all of you, and I thank all our guest lecturers for sparing their valuable time. Thank you, chairpersons. Now I request you all to join us for high tea, which has been laid outside in the dining area. We will reassemble at 4 o'clock for our next session on cardiac MRI.
I welcome you all after the tea. For a second academic session on cardiac imaging, I request Dr. Niranjan Khandelwal, former professor and head of Department of Radio Diagnosis and Imaging, PGIMR Chandigarh, and Professor Dr. Srinivas Reddy, head of Department of Cardiology, GMCH Chandigarh, and Professor Dr. Rupinder Singh, Department of Radio Diagnosis and Imaging, MMU Solent, to kindly chair the session.
Welcome you all for this particular session, which is on cardiac MR. And as you all know, probably this is the decade of cardiac radiology. There are many decades that goes. This decade, I believe, will be next 3-4 years. Stress will be more given on cardiac radiology and its development. And I have the pleasure to invite Dr. Sanjeev Sharma. And in one word, if I had to describe him, his academic appreciation is separate. He is the architect of the modern cardiovascular imaging and intervention in this country. He been trained in PGI Chandigarh, and the loss of PGI Chandigarh is becoming gain in AIIMS New Delhi. And he was the former head and a professor in Department of Cardiovascular Radiology and Endovascular Intervention. And he is instrumental in starting the DM program there. With no more words, you are welcome to deliver your lecture on what is the evolution of cardiac imaging in India, and no better than you who can describe this. Dr.
Thank
Sanjeev.
you, my friend, Mr. Khandelwal, for your kind introduction. Friends, colleagues, ladies and gentlemen, it's a great pleasure to be here today to beat the monotony lockdown and physical meeting after a very long time. I must thank Dr. Pinder and Dr. Manful for kindly inviting. The problem is that they have given me a very tough talk to you. It's a concept lecture, actually. I am not very sure whether many of you may be able to relate to this, but I will try and show you how cardiac imaging evolved and what are current perspectives, and wrongly shared the belief which Khandelwal mentioned just a short ago, that the future of imaging is in cardiovascular imaging. So let me try and see how many of you I can convince to join the bandwagon of cardiac, so the future cardiac radiology. So how did it all begin? Cardiac imaging as old as the discovery of X-rays. Why? Because the first chest radiograph which was done after discovery of X-ray was a chest radiograph, actually. So cardiac radiology in truth is as old as radiology is. But having said that, the impetus for cardiac imaging evolved with this bright young urologist. This gentleman was a urologist in the year 1999. Intrigued by the concept of imaging the heart, he put in a catheter in his own vein, and from his vein into the heart, and walked down to the radiology department and produced, this is the chest radiograph you see here, from his basilic vein into the right heart, and the concept of cardiac angiography was born. Unfortunately, it took many more decades for it to rectify, and modern cardiography as we see today is because of these two great men, two radiologists, Dr. Stones and Dr. Judkins, in the early 1960s, who established cardiac angiography as we see it today. This is the original angiography machine. It took me some time to dig up these images on which Dr. Stones used to work, perform catheter angiograms, and within a few years of the concept of angiography, the concept of revascularization of heart became, so bypass surgery, as we see today, has switches in the late 60s, coronary artery interventions in the early to mid 70s, and thrombolytic therapies in the late 70s to early 80s. They all evolved because of the development of angiography. At the same time, echocardiography was established, and this showed us a way of looking at structural heart diseases as we today. So you saw a nice lecture on sequential chamber localization. All that has become possible because of the early developments of cardiography. Around the same time, nuclear cardiology developed, and that used the concept of investigating myocardial ischemia and when and how you should revascularize a diseased heart because at that time. Cardiac MR actually came into being in the early 90s and cardiac CT in the early 2000s. I will share with you some thoughts on that shortly. So what about India? So cardiac imaging in India actually goes back into early 60s. Two pioneers. Fortunately, I have the photograph of the second great Professor Rajaram from Chennai. So two gentlemen, one gentleman, one lady, Professor Sne Bhargava here and Professor Rajaram in Chennai around the same time did a landmark thesis of the vascularity in chest photograph. That is the first documented publication from India cardiac imaging. The upper panel is Professor Shyam Sharma. He was in pioneer in catheter angiography. My love for cardiac imaging actually goes back to him. I used to see him in late 70s reading those exotic scenarios of cardiac angiograms, and I used to feel how a radiologist can do that. That's very exotic. After that, some episode PGI, and that's where my love for cardiac imaging began. I will share with you shortly. The image down below, Professor Meera Rajani. She is the first structurally trained cardiologist in India. Was in the early days, she went to the famous Greenland Hospital in New Zealand. The AIMS was built by a grant from New Zealand. And because of that grant, there was a two-way relationship between AIMS and Greenland Hospital. It used to be the largest hospital for cardiac surgeries in the world. So Dr. Rani went there, got trained in angiography, and then she came back and started cardiac imaging. So this is pretty much the background of cardiac imaging in India. There is a PGI connect to it. I joined in 80. When I joined, the cardiac radiology used to be taught by Professor Curry, a professor in cardiology, and I used to wonder how is it that a radiologic perspective is taught by a cardiologist at that time, naive, and I thought maybe this is where I should. So cardiac imaging for me, the love goes back to 1980. I finished my MD and actually moved to AIMS and became the first full cardiac radiologist as a faculty. It's my lifetime there actually. I don't regret it. But having said that, cardiac MR in India was performed in the year 1993. We got Siemens Magneton and we did a cardiac MR. That was a patient of atrial septal defect in whom we did a cardiac MR to see the left ventricular function. So that's how it goes back. The first cardiac CT again in the year 2002, we got our first multi-detector 16 smartphone CT. First in Asia, actually it got installed in AIMS. And we started the journey of cardiac CT as you see it today. So having very brief background of how cardiac radiology evolved across the world and in India. So what are the challenges in developing? Why is it that despite so many decades, it is still not established and we are still talking about the future? Why not the present? What are the challenges here? Why is it radiologists don't want to take up cardiology? The reason is because the subject matter is very complex. Why? Because the anatomy is not straight. That's one problem. The second problem is it is largely interdisciplinary. In other words, for a radiologist to cardiac imaging, you must have understanding of the hemodynamics, understanding of electrophysiology. So you are, am I a radiologist or am I a cardiologist? That's where the problem is. That is the boundaries between radiology and cardiology or cardiothoracic surgery are blurred. So go outside into pursue training in cardiac radiology, you will find for every 10 cardiologists, 1 or 2 radiologists are getting trained. Cardiologists are becoming cardiac imagologists, as a full-time profession. This is the reason that is happening. We radiologists have intuitive skills. So when I walked into the department, Professor Sodi will be sitting in one part, and all of us like this, and he would have his intuitive eye picked up the diagnosis in every box. That was what radiology was. But cardiac radiology is a judicious mix of intuitive and deductive skills. I will show you how deductive skills have come into building into reading images in the heart. So to understand this reason why cardiac radiology is not evolving, we need to understand why do we image the heart? What are the objectives? Like for all other body parts across the body, establishing the diagnosis is an important factor why radiology is necessary. But majority of that is anatomical morphologic diagnosis. Fortunately or unfortunately, in the heart, the diagnosis also includes interpretation of physiology and hemodynamic in the heart. That's part of our report. It also includes tissue characterization or pathologic diagnosis. I will show you clinical example of it. It also includes functional and some form of, in the newer technologies, biochemical information also. So we are merged or married biomedical imaging, molecular imaging into the concept of imaging, as you know, in other parts of the body. Also, this is where cardiac radiology actually differs from the parts of the radiology, is because radiology here treatment in true sense of the word. What it means is it chooses what treatment is to be done: surgery, medicine, intervention. It also chooses what the outcome will be. I will show you how images are used to interpret or prognosticate the outcome of it. And it also is used to monitor the outcome of therapy. Also, so therefore, it is a multi-dimensional demand that there is on the radiologist. So the boundary between the radiologist, physician, and surgeon is very blurred. So what I call you is not a cardiologist. What I call you physician radiologist, because you are physician first and radiologist next. That's why cardiac radiology is the future, as Dr. Khandelwal said, because you are not a non-clinical specialist. You are a physician and a radiologist. So having said this, why the heart, which is difficult to image? Because of many reasons. The first reason is that there is no one plane where you can image the whole heart. That's a problem, because it's tilted in all the axes, X, Y, and ZX. The second problem is the heart is a still organ. It keeps moving. It moves because of a variety of motions, and it moves at a rate which is very variable. One moment it is 60, the next moment it can be 200. So there lies the challenge in producing a reliable motion for the image. Second problem is that the hemodynamics change very fast. So patient has a chest pain, patient goes to the doctor. In China, by the time the doctor says the pain is gone, so the hemodynamics change. Why are you going to image? You see it is normal. There lies the catch. Your window of opportunity is very narrow to be able to pick the abnormality. The third problem is the wide variation in density of surrounding tissues. Cavity volume, and that is a much thinner coronary artery. Structures are very small. So therefore, very conflicting demand. You want this imaging technique which has a very high temporal resolution. So which is that technique? Some right. So you have one procedure has a temporal resolution and a poor spatial resolution. Another technique has a high resolution but not a good temporal resolution. But in heart, you want an imaging technique which has both high spatial as well as temporal resolution. So it is these demands on an optimal technique are tremendous. Why no ideal technique exists to image the heart? Choose why we want to do the image, and then we choose an appropriate imaging technique. So let me try and give you some clinical perspectives on what are the paradigms in cardiac imaging. It all depends on the clinical question that you have. For example, there is a picture here. It is a young man who comes to the OPD with progressive heart failure. You can build a diagnostic algorithm based on the imaging. You can build a diagnostic algorithm based on the clinical feature. In other words, so this patient has the ECG was abnormal. Well, this could be myocardial. So you do a procedure according to it. You can do a catheter angiography or CTography. Or this angiogram is normal. I need to do an MR. So a non-ischemic pain has a very different algorithm. Ischemic pain has a different algorithm. A congestive can be the structural abnormalities. It has a different algorithm. Let's see some pictures here. Here is a picture of the heart. This is a short axis view. So what you see is large mass in the posterior to the left ventricle. It is low in signal intensity, and the moment I contrast, it lights up like a bulb. So what lights up like a bulb after contrast in the MR is the fibrous tissue. So is a fibroma. See what I'm trying to tell you is when you use deductive reasoning along with your intuitive picking up abnormalities, you become a cardiac radiologist. Here is another example here. So the patient who's got pericardium, this is the patient who's got, you can see blooming, you can see a calcite hematoma here, tubular ventricles, dilated area. This is a congestive pericarditis with a hematoma in the pericardium, which is calling failure. Another example here, normal structure which are sent to a valve. What lies on the valves? Vegetations or a tumor. So this patient has got a background of low grade fever coming and going. So this is a bacterial carditis with vegetation which is causing this. So your ability to weld your clinical diagnosis, clinical features with imaging is what uses the diagnosis. Another example here, so you will see the typical picture. It doesn't matter whether you see this in the lung or in the liver or in the brain or in the heart. That's how this looks like. Another example here, again the same. So the clinical is the same. A young with a progressive heart failure. That's what we're looking at. How structural abnormalities can produce a variety of radiographs or abnormalities. So here is another young person. What do you see here? You see a big mass which is coming out of the right atrium, invading the heart, out, and extensive enhancement. So a mass. So remember, a young person, rapidly increasing mass, a lot of necrosis, a lot of contrast enhancement. Angiosarcoma. This is a pathognomonic. So what I am trying to tell you is you need to create your own algorithm using these abnormalities. So here is another same situation, a young man, progressive heart failure, but this patient came into the hospital, had a pulse of 20. This is a patient complete shock. And when you look at the so one ventricle, this is the intraventricular septum. So what you see is large aneurysm which is burrowing into the intraventricle. So what lies in the intraventricular septum is the middle of his. So this is what is causing obstruction to the middle of his and causing a complete block. So whenever you see a young man or any man, any woman with a chest radiograph with an abnormal ascending aorta and a passivation in the heart, it is mnemonic of a non-ruptured aneurysm of the non-coronary sinus, which is to the septum. So this patient will be a maker, and followed by that treatment of the pseudoaneurysm. Let's do another clinical scenario. A patient who has an acute chest pain in the emergency room, ECG with plus minus common ambiguity prevails. So ambiguity in life prevails all that. And that's what happens here. What can we do? We can do a form of a CT, try and understand what lies under it. So this is a patient who got, what is this? A large thrombus in the pulmonary. So this is a pulmonary thromboembolism, acute chest pain. Similar situation. Another patient, why this is not checking? Okay. Another patient has got a tight stenosis in the left descending coronary artery. Karthik showed you the anatomy. See a tight stenosis here. So that was a mild infarction. System trying to show its colors to me. Again, Okay. Okay. So this is another patient, similar, same patient, I mean, same clinically. Acute emergency room, chest pain. What do you see here? A type B dissection. So one examination using 3 different outcomes. What is it called? A triple rule out CT. Why do we do it? So in the emergency room, when you don't know whether this patient has got MI or not, we will do this. But if I know this patient has got an MI, I would never do a CT angiogram. I would shift patient with cath lab and do an angiogram. By each contrast now, and then the just gives contrast. He may survive the myocardial infarction, but he will die of a coronary injury. That's not a good idea. So that's where your clinical skill is important in deciding what to do. So what is the learning point here? Learning point here is deductive reasoning. That's what differentiates a cardiac radiologist from the rest of his ilk. Young patient again, acute chest pain again, they're on same paradigm, and we continue with this for a while now. Young patient with an acute pain, abnormal ECG, we don't know, but the enzymes are raised. The moment the enzymes are raised, we know this is acute coronary, possibly. We do the angiogram, it is normal raised. So what do we do? We bring the patient back to the radiology department and do an MR. What do we see here? We see typical contrast enhancement. I don't want you to waste your time on this. Let us believe that this is typical appearance of myocarditis. Acute myocarditis is a differential diagnosis of acute myocardial infarction. Produces almost similar feature. Only difference is that the ECG may be non-specific. Oftentimes, it is not possible to differentiate. You do a coronary angiogram. When it is normal, then you know it's a different diagnosis. This is actually at COVID, and this was a long COVID. In the post-COVID period, came acute myocarditis, was interpreted as acute myocardial infarction. Now, moving forward, so what can a radiologist do in this setting here? We can do categorization, and there are a variety of issues that the MR can categorize. So, an extension of your morphologic reporting is your pathological reporting based on the interpretation of various images. There are diagnostic criteria. We will go into it at some point. But what is also important is beyond the tissue characterization, you can use these images to prognosticate the outcome of treatment. And this is how we do it. So in the setting of acute myocardial infarction, chronic myocardial infarction, we can do risk stratification by identifying reversible versus irreversible areas, by identifying whether the heart is transmural or it is not transmural. So the infarct was less than half the thickness of the myocardium. This patient will do well after revascularization. Ejection fraction improves from 47% to 63% after revascularization. If the infarct is involving almost the whole of myocardium, you do revascularize, which today everyone does, but the patient doesn't benefit. The ejection fraction did not grow. So this is what you need to identify on the edge and let the physician know that, look, this patient is not for coronary angioplasty or surgery, is not going to benefit. We have, what else can we do? We can study the natural history of disease. So here is big panel of images. So this is one of our key areas of interest, infiltrated disease. So lots of work on this, but I don't bore you with seeing all these images. All I want you to know is that here, look at this heart. This is a T2 weighted sequence showing you the bright myocardium, inflamed myocardium. So in the setting of an infiltrative heart disease, we can identify active from inactive disease. Based on certain imaging findings here, we identified this as active disease, treated this patient with steroids, and subsequent to treatment, you can see all that whiteness goes away. We can guide when to stop the treatment as the disease has become inactive. We can also use these techniques to study the natural history of disease. This is a patient of amyloidosis, and at this time, the physical involvement was not much. And over time, how it progresses to evolve thickness of the myocardium being involved by enhanced by fibrosis. So natural history of diseases can also be studied by using various forms of cardiac imaging techniques. But the most important impact that cardiac imaging has made in the management of patients in setting of congenital heart disease. So clinical scenario is at the center, and that's why the physician radiologist at the center of it decide whether the patient see MR or none or both. So how does it happen? Just one example here to show you. So this is a very common form of congenital heart disease, defect. This is a sinus venosa type of effect. This is cross-sectional image, aerial image, showing you the defect between the interatrial septum close to the SVC, and you can see the abnormal pulmonary vein which is draining into the SVC RA junction here. So we have a morphological test here. It's not enough. We need to know whether this is shunting for surgical treatment or not. So we can extend to some another form of cardiac MR, and we can get at the amount of shunt this patient has. So now we know this patient has more than 2:1 shunt. This patient also needs surgery for this. Well, will he come out of surgery? Will he do well or not? What form of surgery do I need to do? So we need to assess the mitral valve in this, whether there is a AV regurgitation there or not. We can do MR. We want to assess the left ventricular function there to know prognosticate outcome of surgery. A good ventricular function, good ventricular size will come up well. So this is what we need. Image morphology defined. This evaluation can be used to define the need for surgery. The absence of mitral valve disease defines a surgical plan, and the assessment of ventricular function decides on surgical and prognosticates the outcome. So see how comprehensive information can be obtained from cardiac images. Now, just a couple of more examples to you. So this is a post-operative tetralogy. These upper panel pictures show you patient has got a pulmonary regurgitation. You have to believe my word for it. And we do a CT angiogram. And what we see is a large aneurysm of the right ventricular outflow tract. So what happens in tetralogy? In tetralogy, is an infundibular piece. All of you know, surgery, what they do, chop off that area and put a patch. That's what is called as a patch in the right ventricular outflow tract. Fortunately, over time, it deteriorates and becomes an aneurysm. So that's the aneurysm that you see. They also remove the pulmonary valve, free pulmonary regurgitation. So the patient has got a tight stenosis in the right pulmonary artery and a aneurysm of the right ventricular outflow tract. All this information we have from images. We put this image further and do an MR, and we show that the ventricular wall is sternum. So the surgeon has to know that the moment he puts the chisel to cut the sternum, patient dies on tape. That's important information. Also show that the left anterior descending artery is draining aneurysm. So if he doesn't know this, he cuts the left anterior artery. He does a great surgery and dies on table because of myocardial infarction. So that's the kind of information the imaging can provide to the treating surgeon. Cardiac radiology is also major inroads into the oncology practice. Most of these drugs have myocardial insult, and we can use the images to identify this myocardial injury by the use of a form of cardiac MR technique. So what have we learned, my friends? We have learned that contribution of modern cardiac imaging to the delivery of health queries beyond doubt. It's unquestioned. We have also learned skill development in cardiac imaging is not difficult, not tough. I can tell you, if you could do it, you guys are smart, you can do it well. All it is of clinical and imaging skills, some intuitive and deductive reasoning, and lots of discipline and substantial application. And you have a cardiac radiologist in you. The question is it enhancing patient care? How do we know that? We will know when the patient's management is showing better outcomes. What is happening today is there is a substantial increase in the demand. So I see 50 CT coronaries being done in some hospitals, lots of coronary scores being done, lots of cardiac MRs being done. We are abusing these investigation centers. The problems are many. Problem related to training, problem related to financial incentives, problem relates to very aggressive marketing, to the fear of malpractice suits, another big problem. And how these physicians think more investigation means care. Unfortunately, that is not true. So we need to stop this abuse by using appropriate use criteria, which many societies continue to publish. We need to become aware of, use them to guide our selection of images. We should avoid excessive testing. It's important. But at the same time, we should also not using or underusing or overusing a technique. It's important to choose the right image for the right patient. But it's also important that we don't deny the right image to the right patient. So that's what I said, judicious use of imaging. What's the future of cardiac imaging? We are at crossroads today, as Dr. Khandelwal said very happy. Why? Because we have rapid technological advances. We are moving from single modality to multimodality today. We use PET CT, we use MR, we use some form of nuclear imaging, we use angiography, all in the same patient. So the practice move towards multimodality. Trend is to provide comprehensive assessment. I gave you examples of diagnosis to pathology, biochemical to prognostication, etc., etc. So the future looks very bright. Actually, we are also moving to phenotyping disease. Cardiomyopathy is very important nowadays. Why? Because we are able to prevent certain cardiac deaths, investigating asymptomatic family members of a given disease, and that's where the phase is very exciting. We are also imaging for drug discovery programs as well. So these are very exciting advances. And most importantly, and lastly, we are in the clinical application of artificial intelligence. If you use the literature today, most of it is in cardiac imaging. Much of it is getting automated. It's getting better in terms of acquisition, in terms of reporting. So the future is bright. Waiting for many of you to come forward and join. Thank you so much. If you have any questions, please ask me.
Thank you, Sanjeev, for wonderfully justifying the topic that has been given to you. And sure, in the hall, there are youngsters who will follow your guidance and will opt for cardiac imaging in the next few years. With these words, if there are any questions, actually so smooth. So there is no question from audience. Okay, I hand over the mic to Dr. Reddy to introduce the next speaker and continue.
I would like to invite the next speaker, Dr. Mansoor Singhal, who is an additional professor at PJ Chandigarh. Professor at PJ Chandigarh. So he has got multiple fellowships on his cardiac MRI and cardiac CT. I know vividly that Professor Khandelwal, once he was there, he has the head of the department. He knew that we started the cardiac CT first time way back in 2006, 2007. When Professor Khandelwal was the director. So that was the time when we started the cardiac CT and followed that. I think now we have got a new cardiac MRI also at PGA. I think Dr. Mansoor Singhal is solely looking after the cardiac CT and MRI at PGA. So he would throw some light on his topic of on cardiac MRI. I think pulse imaging and sequences, which are what are the planes and how to perform cardiac MRI. Because cardiac MRI is one of the, I think, very latest modality to detect all types of images. I think most of the advances have been taken place. I think we cardiologists have also most of the interest in, especially in the cardiac CT, even prior to performing any interventional procedures. So, Dr. Mansoor, please.
Thank you, Dr. Reddy, for your kind introduction. As Professor Sanjeev sir has aptly said, and endorsed by Professor Khandelwal and many other luminaries around the world, the impact of the cardiac imaging, the technologies that we have now has a great impact on the patient care. And the disease which was elusive, now we can find the answers to them. So before we go into that details, I think we should be, stuck to the ground and know the very basics of an investigation.
So I can tell you here when, in 2008, when Professor Khandelwal told me to, why don't you go toward cardiac imaging side, I was very scared. In fact, I thought, I've been punished for this. Let me be very truthful for that. But this had been a wonderful journey. I had a support of many luminaries who was Professor Neil Sharma. I had an opportunity to visit and get trained for a short time there. So with this, let's go to the topic proper. So, I have no endorsement and disclosures. So what are the challenges and what are the various solutions? As we know, we are trying to image a beating heart in a moving cage. So these are the challenges and we'll see how we overcome them. So the beating heart, so we do this compensation by the ECG gating. And with the respiration, either we can use motion compensation by telling the patient to hold his breath, or we can use respiratory gating. And sir has very aptly said, the plane of the heart doesn't lie, straight in any of the axes, the x-axis, y-axis, or z-axis. So we have to create a planes which are akin to echocardiography. And traditionally, we see MR versus CT. CT is a very fast examination with a high temporal resolution. But MR traditionally has associated a long acquisition time and has not that good temporal resolution as what we have seen in CT. So we need to know what investigation to be done at what time. And at the same time, when we think of MR, so we need to think of these three things: appropriateness, acquisition, and interpretation. Because in MR, we have a lot of sequences. So which sequence to be done in a particular examination or for a particular patient makes sense. Because sometimes now we get forms like cardiac MR. I just send the forms back to the clinician. This cardiac MR is no indication. He has to be very, very specific what information is looking for. Say what Sanjeev sir has said, the patient coming for the acute chest pain, coronaries are normal. So it means we need to have the trough levels. We need to have information of the coronary angiogram. How is the patient's status now? So that we can define our protocols. Which means the myocarditis is the question or the Minoca is the question. So we customize our exams accordingly. So if it's a cardiac mass, we will customize according to that. So it is an integration, the sir is very aptly said there is a blurring between the physicians or cardiologists or surgeons with the radiologist. And this blur needs to be, redefined and had to be made crystal clear. So if it is not appropriate, it's painful for all. And the trade-off is between the resolution, signal to noise ratio, and the acquisition time. At any cost, acquisition time has to be customized because every small moment of the magnet has to be respected, and it has to be done in the minimum possible time with the least patient discomfort, which should be defied of artifacts and give you the full information. So my ABC of CMR, this is my customized slide. First is appropriateness and indication. We should be very, 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 very specific for that. Cardiac MR 1.5 Tesla is good enough. 3 Tesla, though it's coming, but I think 1.5 is good enough. And we need to prepare and plan the patient. I always say, if you don't plan, you are planning to fail. Then C is, its heart is a beating structure. So we need to have a fast cine sequence which can cope up and take the good pristine images without any deterioration. And then we have a contrast and dynamic perfusion imaging. Delayed enhancement is for myocardial characterization. Then we'll see the emerging sequences, which is now giving a new insight how we looked at myocardium. There's something like, getting a new stains on histopathology. And at times we need to do flows when we have to look for congenital heart disease or shunt quantifications. You need not to do everything in every patient. It has to be very, very well customized. Every patient that we do it, at least in my place, we don't do without any proper clinical information, and we do the imaging or the cardiac MR as per the clinical needs. In business schools, they teach 5 P's for success, but I modified it to, we need to know what's the prior information when we need to do an MR. We need to have a good preparation, otherwise everything is a waste. Peripherals, we need to check how to prepare the patient, we'll see. And prevents, this is very important, how to make studies crystal clear without any, giving the artifacts. Then comes the performance. So let's go one by one. The motion compensation, if we see the acquisition of a single slice cardiac MR, usually takes around, or the sequences should be such that it should be less than 20 seconds. And if it is a 3D acquisition, it will take several minutes, but that is not desirable. It will kill the examination. For long acquisition times and the breathing motions, they is prone to severe artifacts, is not compensated for. So what we have done then, we will not get diagnostic images. So both these motions needs to be frozen absolutely during that equation. So this is one of the slides that I got from my friend Reda, who works at Singapore now. Earlier he was Bartlett's in London. So it is the beating heart with a moving cage. The heart is beating and it's moving up and down. So both movements needs to be frozen to get a good diagnostic images. Okay, let's see how we compensate both of them. Cardiac motion we can compensate by ECG gating. That's how we do it. This is an RR interval. We try to, if it's a prospected gated single phase scans, it is usually in the diastolic phase. But scenic equation has to be done throughout the RR interval. That is how we get the frame of images that covers both systole to diastole. Then the respiratory synchronization can be asked. Usually we do in end expiration to hold his breath, but most of the patients who are in failure probably will not be able to do that. With that, we can use an EC diaphragmatic navigator. So, that we'll discuss here in these images. So prior, when we discussed about 5P, the patient preparation and setup, this is how the ECG leads are to be placed. And we need to see that no wire should intertangle or, curve with each other, because when these wires go into strong electromagnet, they can lead to electromagnetic current formation, leading to distortion of ECG, and can even lead to the, warming of the cables and burns to the patient. Patient needs to be taught how this examination is going to be, how much time it is going to take, and how he has to hold his breath. Then if you see, we have given this patient, this balloon in his hand. If he is feeling claustrophobic, or for that matter, if we are doing a stress examination, he's feeling too discomfort, he can always alert us. This is the respiratory below, with which we get the respiratory compensation. And with this, when everything is all right, then we have to start our examination. And the good planning is always, this type of planning will reduce the patient time in the bore, and less time in the bore is a better chance of successful study. This is how we get it. This is the ECG. We see the ECG is distorted because of strong magnetic fields, and this is the respiration. So when we tell the patient to hold his breath in deep expiration, that's how where we start our examination. So we have to tackle two things. One is the heartbeat, another is the respiration. Okay, so what we are looking for CMR, what are our goals? When we talk of goals or CMR, we are looking for three things. We are looking for structure, we are looking for function, and we look for tissue characterization. And we have different pulse sequences for all of these. And these all things has to be done in the planes, in the true planes of the heart, not in the planes as of the body, axial, coronal, and sagittal. Okay, this is the basic CMR protocol. We have labeled it as LGE protocol, or late gadolinium enhancement protocol, in which we see the anatomy, then we see the function of the heart in three different planes, and we do give the contrast to see the early and the late gadolinium enhancement for myocardial characterization. If you want to save time, you can put, I'm not going into this, you can put cine sequences just after giving the contrast. Otherwise, in typical well-established MR lab, it will take around 35 to 40 minutes. So let's go to the pulse sequences. So what we are interested in, first we need to know the anatomy, for we do the dark blood imaging, which can be typical spin echo sequences, or the inverse recovery sequences are the way forward nowadays, because we get a very good images. We'll show in examples. There's a bright blood imaging, and the today's workhorse for the bright blood scene imaging is the SSFP sequence, or the steady state free precision sequence. GRE was earlier the sequence, but we didn't, the myocardium to the blood contrast was very poor. Then we use the inverse prepared sequences for our tissue characterization. Then we use phase contrast sequences or the flow sequences for flow quantification. If you have to do an angiography, we can use then gadolinium based angiography. Edema imaging typically is by state sequences, but it's a poor spatial resolution. Additional imaging that has given a new insight is the mapping techniques, and additional imaging sequences are usually reserved for characterizing the tumors. So dark blood imaging, to begin with, earlier it used to be fast spin echo sequences. Now we use a double inverse recovery sequences, and you see these are the sequences that we get. This is a typical T1 weighted sequence. You see the structure, these are the blood. This is a fast spin sequence images are slightly better. But if you see the double inverse recovery scans, it is just like images you get like in CT images and very pristine images with pencil clear margins. Another thing for the black blood imaging is the edema imaging, is the stage sequences. We don't use this sequence in routine until unless there is a clinical concern of myocarditis or myocardial inflammation. Say if it may be sarcoid or it may be myocardial inflammation, we saw some patients in post-COVID era, or for that matter, any viral myocarditis. So state sequence is a short tau inverse recovery scan. It basically is a triple inverse recovery scan, and we image at such a point in which all the background becomes null, it becomes black, and only it's the water content or tissue having water content accentuates. I'm not going into the details of the physics of that as of now, but we need to know this for edema imaging. It is a stair sequence which is frequently used in musculoskeletal imaging. This is this is how the images you get. The black, blood is all black and background is blood, and only the tissue you see in this patient. This is the apex myocardium is so bright. This was a patient of suspected myocarditis. Okay, when we come to the bright blood imaging, it can be static image and it can be cine image. But cine image is for functions, bright static images for anatomy. If you see, these are the GRE sequences on the right side. See the images you see, and you see the SNR on the SSFP sequence over here. Sorry. It is so bright, the static SSFP sequence, and this is the cine sequences. So workhorse for today's modern world cardiac MR is SSFP sequence. Now, what we get with SSP sequence, or it is synonymous with the cine imaging, is for the wall motion abnormalities and the dynamic change as the heart contracts, measurement of cardiac chambers, assessment of valvular morphology and functions. And typically it is retrospective gated scans, which takes the scanning throughout the cardiac cycle. If we have to increase our, decrease the acquisition time, which comes at the cost of SNR, can be parallel imaging, in which multi-slice acquisition cine sequence can be done at the same time. This usually we reserve for patients who have poor respiratory breath hold. Okay, the retrospective gating can be a multi-phase acquisition also, in which you can have, we take multiple slices at the same point at different points of RR cycle or cardiac cycle. That's how we get an cine loop of at that particular plane. This is what we mean a retrospective gated multi-phase acquisition. So here we see, if you take a slice over here, the images has been taken at the different phases of ECG cycle, and that's how we get images from systole to diastole. And the same can be done at multiple planes or multiple slices. It all depends, how fast we can do it and how fast is desirable. Okay, when we come to the concept of dead gadolinium enhancement, this had been till yet as a part of myocardial tissue characterization. If we see even the myocytes are replaced by anything or there is an expansion of the interstitial space, either by fibrosis or fluid, it expands. When it expands, the gadolinium stays over there long time. It gets trapped. So if this is subendocardial enhancement, it is typical of ischemia. What Sanjeev Shah showed in one of the cases of myocarditis, typically epicardial. So based on the pattern, based on its location, distribution, we can characterize the different pathologies. If we see the contrast kinetics, how does it when we give the contrast injection, this is what it happens, and it changes with the different pathologies. If we see, this is the normal myocardium, green one, this is the blood pool phase, and this is red one is the infarcted myocardium. Say we will image over here, so there will be a big difference between the normal and the infarcted myocardium, which will stand out very nicely and appear as bright on LG sequences. Anything which is bright on LG is dead tissue. Okay, so this is first, when we give in contrast, we always take a first pass, then we take an early gadolinium enhancement just after giving contrast, then we do delay enhancement after 5 to 10 minutes. And we can do the tissue characterization based on the patterns of LG. Say if it is transmural subendocardial, it's probably ischemic. If it's epicardial, it's probably myocarditis or inflammatory. If endomyocardial fibrosis, it will be at LV apex, so and so forth. There's a gamut of diseases which you can make based on the clinical scenario, based on your function, as well as on the LG pattern. So what is the basic CMR protocol? Let's see into it. First, we take we know that the heart doesn't lie into the true planes or axis of the body. So we have to need to create a plane. First, what we do is, We take axial, coronal, and sagittal plane according to the body. After that is done, this is the images that you get. You put a shim box on the heart, and you take a stack of axial images starting from, this is the axial stack. We see, sorry, heavy loaded file. So, this is how you get it. You will get all the images from the base of the heart to the apex to the base of the heart. This is akin to your CT images. You basically knows what is lying in the chest as well as in the heart. And based on these images, we start our examination. So this is a step number 2. Then we, draw some pilot scans. So once you get this 4-chamber view, this is not a true 4-chamber view. You draw a line between the LV apex and the mitral wall. This is how you got an VLA pilot scan. Based on this pilot scan and the 4-chamber view, you get a near short axis views. One is at the base, one at the mid cavity, another at apex. Based on these 2 scans, the pilot VLA and the short axis view, you draw the other planes. If a line dissects between the LV and the RV apex, you get a true 4-chamber view. Is it? From here, the MR actually starts. After you get 4-chamber, then if you draw a line which is parallel to the septum, you get a true vertical long axis or the 2-chamber view. Here you get the LV and the LA. Then you need to have a 3-chamber view. Here the lines, has to cross through the LV septum, and you should not be crossing the LVOT view. Here you get a 3-chamber view in which you get the LV inlet view and the LV out view. This is, more important when you are suspecting cardiomyopathy, especially hypertrophic cardiomyopathy. So once you get this, then we evaluate functions and take volumes of LV on the cine axis stack. Till yet, we were taking only one slice, whether it was HLA, VLA, or 3-chamber. Now we are taking the stack of short axis that will come from base to apex. Typically, it is between 15 to 18 slices, depending on the heart size. So this goes parallel to the LV septum and planned on the HLA and the VLA views. But typically, we take a slice thickness. We use a formula of 864 or 82. Slice thickness means 6 mm with 4 mm gap, or 8 mm slice thickness with 2 mm gap. And the temporal resolution that we get should be less than 40 milliseconds between the phases. And parallel imaging, as discussed previously, can be used wherever available. So what you get these stack of images. You get this, short axis stack from base to apex. With this, you can know the wall motion abnormalities, contractility dysfunctions, and so on and so forth. The still sequences are already enumerated. We take in 3 planes, single slices in HLA, VLA, and 3 slices in the short axis to the myocardial edema. And the late gadolinium enhancement, it is just after the first pass, is to look for any filling defects. Say in this patient, there is an dark area which is akin to thrombus. This is in case of endomyocardial fibrosis, which is a V-shaped LV cavity with an laminar thrombus sitting over here. Now, after 5 to 10 minutes, you get again inverse. You take an myocardial inversion time, and usually it is between 250 to 350 milliseconds, and you do an LG sequence. This is a bright blood LG. Now, with this new technological advancements, we have started getting the black blood LG. So, based on this, the LG patterns, we can diagnose different diseases. Flow quantification, as Sanjeev sir has also showed, we do in specific cases, not in everyone. It is just like getting a Doppler-like graphs. You can quantify the regurgitations, you can quantify the stenosis, and typically this is result, say we do typically for post-op patients or for shunt quantification. The near sequences, I will just, give just sensitize you how the CMR is making a new paradigm changes with the way the MR is practiced. We have T1 and T2 mappings, and at the same time extracellular volume estimation. And the way forward is myocardial dynamics in the form of 4D imaging, MR spectroscopy, MR imaging with devices. Now we have broadband technology in which the artifacts, the leads can be avoided. Then you have black blood LG, in which a small enhancement, especially subendocardial, can easily be picked up. So and so forth. New things are coming up. The T1 mapping, another T2 mapping. This is an extracellular volume estimation in which any pathology that expands intracellular component will raise the ECV values. And typically this, it is making a difference, especially in amyloid, in which T1 values will be very high versus T1 values, which is very low in Addison Fabry disease, in which patients will have recurrent chest pain with normal coronary arteries, but T1 values will be very low. A lot of work is being done on T1 mapping and ECV, yes, not only for diagnosis, but for prognostication and management and follow-up of patients. So with this, I will like to conclude my talk. And if you want to go from after this lecture, you must know the pulse sequences are of two types, either they can be static or dynamic. If it is static sequence, either it can be blackbird sequence or it can be bright bird sequence. If it's a bright bird sequence, it is usually a steady state or SSP sequence. And SSP sequence is the workhorse for cardiac MR in which we do cine sequences. The cardiac plane, it looks difficult, but if you start doing it is something which can be easily be learned. You should have a knowledge and application probably is the key. You should not be doing every sequence in every plane for every patient. It needs to be customized, because otherwise cardiac MR, you can linger on for 2 hours. We must ensure that the patient spends the least amount of time with the maximum information being extracted from a single examination. And for myocardial tissue characterization, earlier it used to be LG, but now we have other gamut of the technologies available to us, whether it's T1 mapping, T2 mapping, or ECV estimations. And the sequence selection, as Sir has also reiterated and emphasized, that has to be as per clinical needs. And the newer sequences which are emerging, I think in the coming future are going to give us, will give us more and more tools, how we can look into the myocardium better. And with this, I will conclude my talks on the pulse sequences and cardiac planes on cardiac MR. If there are any questions, I will be more than happy to take. Thank you.
Thank you, Dr. Mankul, for your illustrative lecture and clear understanding what it is. Anyone else got any questions? The audience. If not, I would like to ask one question. What is the role of artificial intelligence in MRI? Because you know that most of these images are only mainly used in a set of individuals to retrieve the artificial intelligence algorithms, like we have now in echocardiogram. So there is algorithms now even for our intravascular optical coherence sonography area algorithms have come. So what is the role of AI in MRI?
If we talk of 2017 when AI was being worked, and the major work was with the CVI42 team working in Canada, and Professor Stephen Peterson was one of the leaders working in that. They used to tell me when we'll go out with manually drawing with circles. Now artificial intelligence is coming in a very big way, not only to get the volume estimation, taking on the inter observer calculation of the LV volumes. Not only that, we can quantify the how much percentage of LG is there. So that say in sarcoid you done one patient, you found LG which is restricted to 4%. After treatment, how much is left? So artificial intelligence is a way forward nowadays. Now earlier when we used to interpret MR, typically used to take 30 to 40 minutes. Now with these new gamuts, artificial intelligence coming into the play, I think the things are going to not only to get easy, but it is going to be more accurate. So there's a lot of future going at, and to my knowledge Google is working on this platform in a big way.
Yeah, that's the main application of AI, giving you the accuracy, maintaining the accuracy or in the different individuals, and it also shortens the time required to give the interpretation. Especially now we have with intravascular imaging, the OCT we have this. I think again this also MRI also is coming up. I think hopefully that would be more precise and give in a lesser time.
I think when everything goes right with the blessing of Param sir, we will get that CVI platform very shortly. And with that, I think we will be able to do justice and we'll give more information in the near future. Thank you.
Now we have Dr. Neha Sekhri. She is a consultant cardiologist. She had probably small stint with Dr. Khandelwal at PGI also. She is having special interest in acquired and inherited heart muscle disease. She is associated with British Cardiovascular Society and is advisor to Royal College of Physicians. She has been awarded with various awards by NHS and has many publications to her credit. And she has publications in prognosis of angina and heart muscle diseases. And her topic for today is pragmatic approach for interpretation of CMR. I invite her for her lecture. Thank you.
Infarction, and she was rushed to the angio lab. The coronary angiogram surprisingly showed no coronary disease.
I think this recording is halfway. It needs to start from the start.
An MRI scan, and you can see that there is extensive MRI scanners. So it's not a surprise that we perform over 8,000 CMR scans a year. Evening. I'd like to start by thanking the organizers of the Chandigarh chapter of radiology, especially Professor Singhal and Dr. Ravinder Kaur, for this kind of invitation and providing a platform to share my experience of this emerging imaging modality, which is cardiac MRI. It is indeed my privilege to be able to share my views with such an esteemed faculty. I have no financial disclosures. I am a clinical cardiologist and I am both a provider and user of a cardiac MRI service. When I started my training, we had only 2 echo machines in the cardiac department. And by the time I finished training, we had 3 dedicated CMR scanners. So it's not a surprise that we perform over 8,000 CMR scans a year. Interpretation of CMR is a broad topic, and in this talk, I will try and provide a brief overview on the indications and interpretation of images supported by clinical vignettes. Consensus panel report on indications was published in 2004, and by now, CMR is widely accepted and strongly endorsed by cardiac societies worldwide. The US CMR registry showed that 75% of the indications for cardiac MRI include assessment for heart muscle conditions such as myocarditis and cardiomyopathies and ischemic heart diseases. But perhaps the most important finding was that it showed CMR had impacted on clinical management in 62% of the cases. This is no small feat. Routine CMR scan provides a large variety of parametric data. This can help answer some of the clinical questions, thereby helping patient management. A basic CMR study should enable you to make an assessment of cardiac anatomy, cardiac function, and tissue categorization, which is perhaps the most important feature of CMR. And tailor-made sequences can help answer specific questions. In addition, a stress study can provide information on myocardial fusion and all of this without exposure to iodine radiation. Fusion, and all of this without exposure to ionizing radiation. So, depending on the question asked, we can decide on the sequences needed to help answer the question. A CMR report should be structured and capture all of these headings and try and synthesize the end in your conclusion. Let's look at each of these in turn. The first, extracardiac anatomy. Well, dare I say, all of you are experts in this, and I will not spend much more time, but show you some few examples of recent cases that caused a change in management. These were not indicated on the initial request for a CMR scan, and this is not uncommon. This study in 2009 showed that major extracardiac pathology was found in about 3% of the studies and predominantly involved in retinopathy and lung abnormality. This is an example of a case with previously unrecognized mediastinal lymphadenopathy, and the biopsy showed Hodgkin's lymphoma. This is the mass, the left lower lobe, which was then found to be a pulmonary carcinoma tumor. The right azygous lobe, which is an incidental finding, presence of liver mass, which later got diagnosed as HCC, mediastinal lymphadenopathy, spinal deposits, and a Holbein arch. Moving on to assessment of cardiac anatomy and function. As has been discussed in the previous talk, techniques of ECG gating involve synchronizing scanning with the QRS complex on the ECG, and this has greatly facilitated cardiac imaging. The tallest wave of the QRS, usually the alpha wave of the QRS complex, is commonly used as the trigger. Cardiac CT scan are then typically applied over several heartbeats out of 10 and reconstructed into multiple phases, about 30 or more, of the cycle to show dynamic function. This provides pictures like these, which we can use to visually assess for atrial and ventricular abnormalities in terms of size, thickness, and assess function, and also look for valvular abnormalities and morphology. Software programs can help make objective assessment of the ventricular function by drawing endocardial contours in end diastole, when cavity size appears largest, and end systole on the right, when the cavity size appears smallest. And using simple formulas, you can get ejection fractions, but the software programs calculate this for you. So it's not surprising that CMR is considered to be the gold standard for assessment of ventricular structure and function. Moving on to assessing morphology, the images on the left are of those with patient with normal wall thickness, normal function, and contrast this with images on the right, which show belly wall thickness, and the phenotypic features are consistent with those patients with hypertrophic cardiomyopathy. Looking at this in more detail, this is a patient with hypertrophic cardiomyopathy and outflow tract obstruction. You see asymmetrical wall thickness, presence of systolic anterior motion of the mitral valve, outflow tract turbulence, presence of posteriorly directed jet of mitral regurgitation, and a dilated atrium. This is a patient with predominantly a mid to apical thickness, and you can see that there is development of cavity, which we know can predispose to ventricular hernias. This is a patient with predominantly mid-peak cardiomyopathy, and you can see there is a turbulent jet arising from the cavity. And lastly, this patient whose wall thickness is predominantly on the lower wall, something that may not be very well appreciated by routine imaging using echocardiogram. And the information that we receive from this simple assessment is relevant for patients' clinical management. CMR also allows better appreciation of right ventricle. As you can see, this is a case of arrhythmogenic right ventricular cardiomyopathy. And you can see abnormality on the RV field wall and the presence of a thrombus in RV apex. CMR can also help monitor patients with heart failure and assess response to treatment. As you can see, the ventricular function improves, and this was a patient who had presented with acute sepsis, and this was likely stress from the acute sepsis that caused the LVDation. Contrast this with another patient who presented after a collapse of a gathering and then complained of chest pain with ECG changes. The left ventricle suggested ballooning of the apex. So the clinical suspicion was this is likely Tatsuba, and it was minor coronary atheroma also on the angiogram. The echocardiograph CMR scan following this shows images which would keep in with Tatsuba with hyperdynamic basal systolic function and almost akinetic mid to apical function, and on follow-up, the ventricular function has resolved. So this is a case of episodic cardiomyopathy. Using real-time imaging, we can help demonstrate that diastolic septal bounce much better, and this is very characteristic of patients with constricted pericarditis. Moving on to tissue characterization, this is perhaps one of the most important gifts that CMR has provided. We use gadolinium chelates, and some of the commonly used agents are listed here. Our experience predominantly has been with butyrin. We look at the site of scar or late gadolinium enhancement, subendocardial or transmural being suggestive of coronary disease. Mid-wall and subepicardial likely due to non-cardiac causes, with diseases like sarcoid presenting more with a heterogeneous pattern of scar. Amyloid generally has altered linear kinetics. This is an example where you see a very thin akinetic to dyskinetic mid to apical anterior wall. And looking at the extent of late gadolinium enhancement, you see there is extensive transmural scar, which is indicative of previous myocardial infarct. Using cine function and the extent of GAD, we will report this as viable and non-viable. And to make this summary, we use the AHA 17 segment model. Based on the thickness of the GAD, we make 11 out of 17 segments non-viable. And this is important because you can see that no amount of revascularization will improve the function of this heart, and treatment is medical therapy only. Contrast this with this study, where you see mid-wall and subepicardial pattern of late gadolinium enhancement, as highlighted with the white arrows. And on T2 stir imaging, you see co-localized edema. We would summarize this as saying non-ischemic pattern of subepicardial to mid-wall scar with co-localized edema, findings suggestive of myocarditis. The etiology needs to be considered in the clinical context. And the reason to put that additional sentence is because myocarditis is not a diagnosis on its own. When diagnosing a patient with myocarditis, we need to always look for a cause for this presentation, and CMR scan may not always find you the cause for why the patient presents with myocarditis. Here are two patients, both of whom presented with very mild shortness of breath. The ECG showed complete heart block for both, and echo reported preserved systolic function. CMR in the first, patient showed mid-wall scar and led us to consider diagnosis of inherent cardiac conditions, and we went on to diagnose AC11 disease, which required implantation of an ICD, and screening of first degree relatives for the patient. The second patient, the pattern of scar was heterogeneous, and we went on to make diagnosis of sarcoid, hence changing the management and initiating immune suppression. These are three very different patients who will have severe systolic dysfunction. We do not know what the cause of dysfunction is in each of these patients, and here comes the role of cardiac MRI, as this may influence prognosis. In the first patient, the pattern of scar was mid-wall, and we went on to find a mutation in intestinal plaking. So it was an inherited disease. And again, this patient went to have an LCD and screening of first degree relatives. In the second patient, we find subendocardial scar. Went on to have a coronary angiogram and showed significant three-vessel disease. In the third patient, we find heterogeneous scar, and this patient was diagnosed with sarcoidosis. These are three patients with thick hearts, and the CMR scan in the first patient showed subendocardial scar, altered cadmium kinetics, and we made a diagnosis of AL amyloid. In the second, using T1 parametric imaging with mapping techniques, we found diagnosis of Fabry's disease. And this patient needed enzyme replacement. And in the third patient, a diagnosis of TTR amyloid was made, and with tafamidis being advocated as a drug, this would alter this patient's management should he be eligible for the same drug. Moving on to stress perfusion imaging, there is clear evidence that this is non-inferior to other modalities of stress imaging. In this case, it is seen an area of reduced signal, which appears dark in the septum, inferior, and the lateral walls. This is not seen at rest, and the coronary angiogram shows significant invasive disease. At our center, we perform both stress and rest scans, and you see in this study that there is reversible perfusion defect in the anterior, septal, and inferior segments. And this led to this patient undergoing a coronary angiogram. We see that there is significant left anterior descending disease, and also not insignificant disease in the right coronary artery. Let's look at a few other case examples in detail. So this is a 60-year-old gentleman who had undergone an echo assessment at his local center for symptoms of breathlessness and a diagnosis of non-obstructive hypertrophic cardiomyopathy was made. He also had chest tightness, so they did an angiogram, and that only showed minor atheroma. However, he continued to have ongoing symptoms, and that is why he was referred on to our center. ECG shows left ventricular hypertrophy, and the echocardiogram here shows septal hypertrophy, reduced in the longitudinal function. And because of his symptoms, we went on to do a cardiac MRI scan. The cine function showed us what we already knew by echocardiogram, so that was not the reason to do the MRI scan in this patient particularly, but physical characterization showed altered gadolinium kinetics, and you can see there is a ring-like pattern subendocardial on the short axis stack. There is suboptimal nulling of the myocardium, and this is to consider a diagnosis of amyloidosis. We proceeded with an endomyocardial biopsy, and he was found to have AL amyloid. This is a second case of a 38-year-old lady who presented with worsening symptoms of breathlessness. She had a plethora of cardiac risk factors, and the initial impression was that she would have growing coronary disease. It was an ECG showing that by branch block, and we will agree that chest X-ray shows cardiomegaly. An echocardiogram was performed in the first instance and confirms severely dilated left ventricle with impaired function, impaired artery function, and very dilated atrium. So with the possibility of coronary disease, she underwent a coronary angiogram, but this did not show any very significant coronary disease with normal arteries. So what could be causing her to have a severely impaired ventricle? A CMR scan was performed, and you can see on late gadolinium enhancement, there is patching, both subepicardial, subendocardial, almost transmural at places, a scar, and there is also seen involvement of the pupillar muscles. Sarcoid is a likely differential. We proceeded to do a CT chest, and that showed parenchymal change, which could be consistent with sarcoid. Based on further clinical assessment, this lady was then diagnosed with cardiac sarcoid and started on immune suppression. The third case is that of a 52-year-old gentleman who is an ex-smoker and a previous ex-heavy drinker. He also has family history of premature coronary artery disease. And though the initial feeling was this is likely alcohol-related LV dysfunction, but in view of the coronary disease family history, we moved on to do a cardiac MRI scan. The stress perfusion scan shows perfusion defects in the anterior, septal, and inferior segments. Tissue characterization shows not significant amount of subendocardial scar. So again, pointing that there is likely to be some coronary disease. And this led us to performing the coronary angiogram, and he had severe 3-vessel disease. He underwent coronary artery bypass graft, and follow-up CMR scan 6 months later shows a significant improvement in his ventricular function compared to presentation. So this was a retrospective diagnosis of extensively hibernating myocardium and not dilated cardiomyopathy, and CMR helped change his management and his prognosis. Moving on to the next case is that of a 26-year-old who has an established diagnosis of antisynthetase antibody syndrome and already on tacrolimus. She presents with more chest pain and a significant troponin elevation. ECG shows inferior ST elevation, concerns regarding myocardial infarction, and she was rushed to the angio lab. The coronary angiogram surprisingly showed no coronary disease. That was baffling. She goes on to have an MRI scan, and you can see that there is extensive myocardial involvement and the presence of extensive scar with recent admission chest pain caused us to consider a change in immune suppression, and this was all felt to be related to her underlying diagnosis of connective tissue disease. And the last patient I share with you is that of a 47-year-old male. He presented with chest pain and a high history of hyperlipidemia. He traveled recently to India, had been unwell. The D-dimer was raised, and he was a differential, but the CTP was negative. He returned back to India, to the UK, and ECG showed non-specific T-wave inversion. He had ongoing symptoms. He was seen in one hospital, and a CT coronary angiogram was performed, which showed minor atheroma. With ongoing symptoms, he presented to another hospital, and they did a coronary angiogram, which also did not reveal anything, unsurprisingly. It was started on antiplatelet agents and then sent to us for further assessment. The tissue categorization after imaging shows subepicardial scar in the inferior to lateral segments, and in view of this presentation, our possible differentials include acquired myocarditis, or that it may be part of a spectrum of inherited cardiomyopathy conditions, the etiology of which will need to be considered in the clinical context of his family history, and he is currently undergoing assessment. But the most important intervention that CMR made, in addition to change in diagnosis, is that this patient does not need antiplatelet therapy. So hopefully, I demonstrated that CMR occupies an important role alongside other imaging modalities. And perhaps most importantly, we need to consider etiology, and helps us also monitor response to treatment. As with everything, interpretation of CMR is in keeping with the clinical context, the function, morphology, and pattern of injury. There are three conditions listed here. Cine images may not give you all the information, but the parametric imaging using sequences like STIR and tissue characterizes patient using plate gadolinium enhancement or gadolinium contrast can greatly influence your diagnosis that can lead to change in management. And finally, as said previously, the CMR report needs to be structured, capturing all these details and the conclusion to try and bring the findings together. So in summary, CMR has many uses and indications continue to expand. And hopefully I've convinced you about the important role it can play in making a diagnosis, a change in diagnosis, and influencing prognosis. With that, I'd like to thank you for your attention and acknowledge my team at PASS and the patients who provided us with this wealth of data, and a special thanks to all of my colleagues listed for sharing some slides that are presented in the presentation. Many thanks for your attention.
I would like to have some questions. If anybody has some questions from the audience. Any comments, sir? Thank you, Dr. Neha, for your very nice and informative talk on CMR. And thanks a lot for your participation in this Chandigarh chapter of IRIA. Thank you so much.
Thank you for your attention. Thank you.
Thank you so much, all the chairpersons, for sharing the session. I hope that was an informative session. I thank all the guest lecturers for sparing their valuable time. All the faculty and delegates are requested to join us for the dinner at Taj Hotel near the pool site, Sector 17, Chandigarh at 7:30 p.m. Tomorrow, we will begin with our session on oral papers at 8 a.m., which will be followed by academic session on thoracic and abdominal imaging. We request all the participants to be punctual for the session. Thank you.